we're here today, starting off what we hope to be another good streak and a good trend in terms of people coming to our event. So thank you very much. To those of you joining us online, thank you as well. You're very used to doing live podcasts, so I almost started this session by saying welcome to the Free Marketeers, but at least I didn't do that. So those of you who are here live on YouTube, thank you very much for being here. For the media joining in, if you have any questions, please just put your name and your publication in the comment section on YouTube, and I'll present those questions to the speakers at the end of the day in our final session. Just a final point as well for those of you who are here and those online, if you want to tweet about the event, you can tag the FMF at FMF South Africa with your insightful comments and analysis. Maybe tag our Minister of Health, who's busy with his own news this week, but let's see if we can keep him busy with some other thoughts to keep his mind occupied. Just a final note on our speakers, of course. We have Michael Settas, who's a member of the Free Market Foundation's Health Policy Unit. We also have Patrick Bracher, Director at Norton Fulbright. And finally, we have Professor Alex van den Heever from Wits, and he will join us later today. Now on to my short introduction and overview, just to give you an idea of the FMF's position on the NHI, and then we'll get on to Mike Settas. So why host this event now? There's a few other things in the news, of course. South Africa is now dealing with its third wave of COVID cases, so there's a lot to occupy South African minds, of course. But we believe healthcare is probably one of the most important things in people's lives. That's why the FMF believes we should always be talking about the NHI and how new policies might affect people's healthcare. Few things are as important to people as their healthcare. The FMF believes we can contribute in a meaningful way, in a rational and moral way, to solving the country's economic and social problems. And finally, in a world recovering from COVID, we believe that policies underpinned by the following will alleviate South Africa's problems: free markets, free minds, and free people. The current state of play, the state is unfortunately at the moment, as a rule, incapable of running many things, and it's also running out of funding. The inefficiencies and tragedies associated with the public healthcare sector are becoming all too common. Eskom's debt, we heard yesterday that Eskom managed to slash about 80 billion from their debt bank, which is a credit to the CEO, Andre de Ruyter, but it's of course nowhere near where it should be, and we don't think that creating a new SOE in the form of the NHI will go any way to solving South Africa's debt burden. And also the NHI won't solve the country's increasing health misspend, and for that we refer to the latest report from the Auditor General that we also encourage all of you to go and read in terms of the different departments and how they're misspending their health allocations. The over-involvement of the state tends to lead to less desirable outcomes. There is no objective reason to believe that the NHI will perform better than the country's other SOEs. There is, of course, great room for improvement in the public healthcare sector and in the private sector. We shouldn't discount that. But there is no reason to presume that nationalizing the management of all healthcare in the hands of state bureaucracy will solve these problems. This is in effect what the NHI would entail. The FMF's alternatives and alleviating measures, the power in the hands of the citizen. Financing healthcare for the poor, preferably via state-sponsored vouchers, which the indigent can spend where they choose. Encouraging more private hospitals by deregulating the industry and eliminating certificates of need. Reducing prices and increasing healthcare quality through increased competition. Allowing the private sector to train doctors and nurses. The country is suffering from a shortage of doctors and nurses. We need to make it as easy as possible for people to be trained. Encouraging income-producing medical tourism. Retaining skilled South Africans and attracting others by removing the limit on skilled foreign doctors. Deregulating medical schemes so they can offer their clients exactly what they want. Deregulating pharmacies. Removing price controls, which send mixed messages to the industry. The Minister of Trade and Industry, Minister Patel, recently spoke about increased localization measures, and we think that kind of thing points exactly in the wrong direction. Speeding up registration of clinical trials. Giving those who pay for their own healthcare a tax deduction. Strengthening IP rights that encourage innovation, better products, and ultimately lead to cost savings. And finally, probably the most important, allowing low-cost benefit options. The NHI is not the kind of structural reform that South Africa needs. We hear the buzzword of radical economic transformation and radical structural reform quite a lot, but we don't think that policies and ideas that increase the power of the state are the kind of structural reform that the country needs. South Africa should not pursue policies and plans that could add to the growing debt to GDP ratio, placing a greater burden on future generations. NHI will not alleviate the problems in the public healthcare sector, nor those in the private sector. It will not solve current corruption-associated hurdles, and as I mentioned again, the Minister of Health, according to Daily Maverick, has been implicated in some dealings in the last while, so we don't see any reason to think that concentrating power in the hands of the state will lead to better outcomes in terms of things like state capture. South Africa needs policies that unlock and encourage economic activity, job creation, and progress. We need dynamism, not stagnation. And finally, the NHI is not the appropriate vehicle for South Africa to attain better universal health coverage. A final thought in terms of risk versus reward. If we implement the NHI and we get it wrong, as the FMF expects we will, it will be almost impossible to get rid of. So we must actively avoid adopting it. It will be impossible to get rid of because the moment it is implemented, citizens will be paying into it and expecting to get something out of it. The system will usually fail them, but they will not want it abolished because of the money they've already sunk into it. We should rather not go down this unfortunate route to begin with. The NHI is ipso facto a terrible idea. Thank you. I will now hand over to Mike Settas, who will give us his first presentation of the day. Thank you, Mike.
Great, thanks Chris. Welcome everybody. Thanks for your time, and to those online as well. Thanks for your time here today. In a public setting without a mask, I feel a bit weird, you know. It's almost like I'm doing something bad, but let's hope not. Okay, well, thanks Chris for the introduction. Today, my sort of take is to have a look at the policy process that the NHI has followed, plus some of the high-level fiscal implications, and then just briefly at the end, what are some of the alternatives that we could have a look at. So in terms of the policy process, I thought it might be apt to have a look at some history on health policy process, or health policy in South Africa. And it goes back 2.5 decades, so you can see over there, started with just at the dawn of our democracy, an ANC health paper that was written, the establishment in the late 90s of the Taylor Commission, which did some very good work. The Medical Schemes Act was passed in 98 after work from the Malamet Commission. The Taylor Report, after a good 5 years, developed a social security proposals, which was much broader than just healthcare, but within that there was the proposal for a social health insurance. In 2004, prospects of building a low-income medical scheme option was also on the table. That didn't last very long though. It was cancelled by 2006. By 2007, the Taylor proposals had been abandoned, and principally you can just have a look at the year there. Obviously the changes in the political landscape is really what prompted that change. There was also a proposal to change the Medical Schemes Act in that amendment bill, and that was also abandoned. And 2008, the NHI proposal was born. So it's been on the table for a good 12, 13 years now. The Green Paper came out in 2011, a White Paper in 2015, and then another attempt at building low-income medical scheme options, but it started and ended within the same year in 2015. A second White Paper was drafted and published in 2017, and the low-income medical scheme options started for a whole third time. By the time we got to 2019, the NHI bill had been passed by Cabinet. The Health Market Inquiry had finished its 6-year investigation into the private sector and produced its findings. Touch more about that later. And LIMS ended for a third time, so quite a lot of yo-yoing around. But in terms of this whole timeline of 25 years, there's only one substantive piece of legislation with regards to health funding that was passed, and that was the 1998 Medical Schemes Act. So a lot of proposals on the table, a lot of research done like the Taylor Commission, various aspects, but not really much cemented in terms of changing healthcare in South Africa. So it's just to give a little bit of a policy background in terms of where South Africa has been for the last 2.5 decades. But to come back to NHI, I want to touch on in terms of the policy process, obviously any policy that gets put forward needs to have a problem statement as to what that policy is intending to fix. And if we have a look at this as the policy statement from government in terms of which was in the socio-economic impact assessment. So it states here the South African government is committed to the goal of universal health coverage. However, to date, progress towards this goal has been limited by the existing health financing system structure. Okay, so in essence, and I underline the two parts there, that's my own emphasis to say, so we focus on universal health coverage and the existing health financing system. And it's been sort of reiterated by comments like this from Dr. Mkhize, who's our current health minister, but it quite easily could have been his predecessor, Dr. Motsoaledi. So responding in a recent parliamentary QA session, Mkhize said that the primary reason for the shortage, that is of doctors, is that the public health sector has not increased in real terms in the past 10 years. And this has impacted on the number of staff that can be appointed. Okay, so very much talking to financing as an aspect of the problem statement, and as a result that we can't achieve universal health coverage. So to summarize what that problem statement is saying is South Africa does not have universal health coverage. The shortage of doctors is because the public health budget has not increased in real terms for 10 years. And this has impacted on the number of staff that can be appointed in the public sector. So that's just a summary, a praise of what they're saying. That's the problem statement. So from our point of view then, let's go and have a look at, let's interrogate that. And that's what we've done in a whole lot of research that we've done over the last few months. So on the point of universal health coverage, I think this is a key aspect of the policy that has been incorrectly defined from the very get-go. We need NHI to get universal health coverage. Okay, but let's have a look at it. This report from the International Labour Organization found no coverage gaps in South Africa from either an inability to pay or from a lack of access. So in other words, we do have universal health coverage. The World Health Organization and the World Bank reports, I think also of 2017, found South Africa had a service coverage index of 0.67. 1 is perfect, 0 is non-existent, but 0.67 for a developing economy is very good. So we have a high level of universal coverage. And then the third and last reference on it more domestically, the Health Market Inquiry found that South Africa provides near universal access through combination of publicly available services and the regulated private market. Okay, so the aspect of universal health coverage, and I think is a key point we need to put here, we don't have a problem in terms of universal access. We have a problem in terms of quality in the public sector, and that I think is more the essential, and we'll come back to that later. The other aspect then of the problem statement was that the public sector budget has not increased in real terms in the past 10 years. So again, let's go and interrogate that and have a look. So on the table that you have over here, we have the provincial public expenditure from 2010 to 2020, so a nice 10-year period there. The column in white is showing the expenditure in nominal terms. And if we have a look at that, it went from 92 billion to about 216 billion over that 10-year period. But we obviously need to account, to create a value around that, we need to account obviously for inflation and obviously for population growth over that time. So in the blue column, if we have a look at the real expenditure, and we've set the prices on the 2010 value, so in real terms then, there's been a 50% increase in health expenditure over that 10-year period. That's stripping out inflation. We still have a 50% increase in the real value. We obviously also need to take into account for the population growth, which has grown quite a bit in that 10-year period. The uninsured population being the total population minus those on medical scheme cover. Then we have a per capita expenditure in real terms that has gone up by 28% over the last 10 years. In complete and total contradiction to what is stated in the problem statement that we need NHI because there's not enough funding. There's been, in fact, very handsome growth in expenditure within the public sector over the last 10 years. And even more so because that 10-year period, we decided to go and have a look at another report which was done by National Treasury, which went back a bit further. And we found that from 2001 to 2016, again, the white column is in nominal terms, the blue in real, and the green in real per capita. So nominal grew very substantially over that 16-year period. And then when we have a look at real, we set it here in 2016 values, But again, we see a substantial increase in real terms of 135% over that 16-year period. Okay, very, very substantial increase. Again, if we obviously have to look, to be relevant, we have to look at it on a real per capita basis. But again, there we see a 94% increase in real per capita expenditure in public health sector over that 16-year period. So now, if we've got data here up until 2016 on this analysis. So if we marry that to the previous slide that we looked at and just have a look at the last 4 years in that from 16 onwards, even in real terms for the last 4 years, there's been a 12.2% increase in real per capita expenditure. So if we marry that to the previous slide showing data from 2001 to 2016, we can comfortably say that public health expenditure has doubled in real per capita terms over the last 20 years. A very, very substantial increase in public health expenditure. So it doesn't marry with what the problem statement has been constantly, that there is insufficient funding. Okay. This kind of lack of funding aspect has also been sort of transposed into another statement, and this has been used in both white papers and in the socio-economic impact assessment to state that the current health financing system punishes the poor. These are the statements made in terms of advancing the policy, the NHI policy. But if we have a look at this analysis, this was a study done by Econex in, I think it was 2017, if my research note shows, yes, it does say at the bottom there. What this shows on the left-hand bar is the source of financing for public health, and on the right where that, how that public health, how the public services are expended across 5 quintiles. And on the bottom, you'll see the 5 quintiles there. Quintile 1 is, so the quintiles are split into 5 equal share of population by households. Quintile 1, right at the bottom in the light blue, is the poorest quintile, and the dark blue at the top is the wealthiest quintile, quintile 5. And here you can see is quintile 5 contributes 68% to public health funding and consumes 12.7% in and of itself. But if we combine the 2 top quintiles, 86% comes from the 2 wealthiest quintiles, quintile 4 and 5, providing the overwhelming majority of the financing required for public expenditure, which is then you can see spread much more evenly across the right-hand side bar, which shows where the public sector's expenditure is occurring in terms of benefit to the population. And we see the wealthiest quintile, that red circle that's flashing there, is the only quintile that receives less in terms of benefit than what it contributes in. Every other quintile below that, 4, 3, 2, and 1, receive more out of in terms of benefit than what they collectively contribute into that. And the point about this, to emphasize, is this structure is very much in line with the social solidarity principle of the wealthier paying for the health costs of the poorer. So it cannot by any measure be considered to be a health financing system that punishes the poor. Quite to the contrary, if you actually see at the poor at the bottom, their contribution is very low, which is understandable. Obviously, that we accept that. But the benefit out of it is much greater, and we're all happy about that. But it cannot be described as a system that punishes the poor, which has been part of the policy process contained in both white papers and in the socio-economic assessment, impact assessment. So to come back to the government's problem statement, we've touched on the universal health coverage and some of the financing aspects, but now the shortage of doctors. So it's impacted the number of staff appointed. How quite, I don't know, but let's have a look in terms of what the actual numbers are. So this is a study also undertaken by Treasury and amongst a few other departments. And we track here public sector medical personnel from 2006 to 2016. And you can see there a very substantial increase again, a 42% increase in the rise of number of personnel employed. Not posts, just to emphasize, this is actual employment numbers within the public sector. So it's a 42% rise. If we account again for population growth, the ratio of doctors per 10,000 population, the ratio of medical personnel to population increased by 25% over that period. So there's been a very steady, very strong rise in the number of medical personnel employed in the state. On top of that, we also had a look at what the wage increases are in the Department of Health. And I suppose this graph is not really much of a surprise. There's been, in real terms, a 55% increase in wages, average wages over the period 2006 to 2016. Obviously, this is the white elephant in the room that our Finance Minister, Tito Mboweni, is obviously emphasizing is where our fiscal problem is coming, is that wage increases have far exceeded inflation for so long. In real terms, it's consuming up an ever bigger portion of expenditure. And it's amply reflected there. That is the Department of Health specific figures. Those are all post-clinical and non-clinical. Another aspect then to look at in terms of expenditure is how do we compare internationally? Because obviously the analysis we've looked at here is only internal within South Africa in itself. So what we decided to do a little sort of experiment here is we took South Africa's per capita GDP and we then doubled it to whatever that was, and we chose the country that was closest to double South Africa's per capita GDP, and then chose all the countries between South Africa and the country with double. So that gave us a cohort of about 25 countries, including South Africa, from which we then decided to do some analysis in terms of their health expenditure and their outcomes. So you can see that list there. I think virtually everyone a developing economy, just much like ourselves. But the emphasis here is that all of these countries are wealthier than South Africa on a per capita GDP measure. Okay, so we're the poorest in this graph. So if we have a look here, on the bottom horizontal scale is the per capita GDP, and on the left scale, on the vertical, is the health spend, also per capita GDP in the public sector. So South Africa is on the far left on per capita GDP. As I said, we're the poorest country in this cohort of this analysis. And then we have a look at how our health expenditure on a per capita basis also compares with these 25 countries. And we see there that in the red block, there are 14 countries out of the 24 that spend either the same or less than South Africa, although they're much wealthier than South Africa. And there are only 3 countries that spend significantly more than South Africa, than you saw there in the 3 red graphs. So out of the 25 countries, 22 are pretty much all in, not all in line, but certainly not well in excess of what South Africa's expenditure is. There are a few that are slightly more, but the vast majority are either the same or less in terms of per capita spend. Now, if we take that same data and we then analyze against, again, the health expenditure per capita up on the left-hand side and compare it with the 5-year mortality rate in the country, we see a totally different picture come out again. So South Africa is now on the far right hand with the 3rd worst outcome in terms of 5-year mortality rates, within that expenditure that sits quite in the middle of that grouping. And you can see in the red block there, there are 14 countries inside that red block that spend either the same or less than South Africa on per capita GDP. And most of those, I think it's 10, achieve significantly better 5-year mortality rate than South Africa does. So our expenditure is right up there with the richer peer countries, but certainly our outcomes are lagging far behind if we take just this one measure. If we go and have a look at infant mortality and maternal mortality, we'll see exactly the same picture arising out of that. Again, our expenditure level doesn't quite marry with what the outcomes that we should be getting with that expenditure level. And just, I think, as a matter of reference here, you might have noticed this one country that sort of pops up with expenditure well in excess of anyone else in this group, and that country is Cuba, which obviously, as we all know, has got a fully nationalized health system. Its expenditure sits at about 13% of GDP, which for a developing economy is virtually, in fact, it's the only outlier in the world in that space. But again, to emphasize, that's a nationalized health system, very much what the NHR proposals are proposing. I would say with South Africa's enamored relationship with Cuba, that the NHR proposal has pretty much been modeled on what the Cuban health system is. But and there you'll have it, expenditures way through the roof. So just to conclude in terms of the policy process and what that came about, we come back to this policy statement that was presented in the SIA and in the white papers. Well, now this is the data we've looked at, but health expenditure in real per capita terms has doubled in 20 years in the public sector. Our expenditure compares very favourably with our richer peers. So certainly there's not, even by international comparative persons, are concerned with expenditure. The financing system also embraces the principles of social solidarity, so that there's a great subsidy from the wealthier to the poor in terms of allowing them to access healthcare. And then the last point is the universal health coverage argument is we already have universal health coverage. There's no policy, there's no need, there is no problem with regards to health coverage. It'll be the quality of the healthcare which is the issue, and that we'll touch on possibly later. So that was the review of the policy process. The idea now is to have a look at what the fiscal implications are of the NHI proposals. And I think at very high level here to break it down here between private sector and public sector. So the private sector is mainly funded through voluntary contributions by members to medical schemes, and there's obviously also out-of-pocket expenditure by both insured and uninsured citizens on the private sector providers. And the figures we get to there are about 4.6% of GDP and a total expenditure of 234 billion. We used the 2019 figures to make sure we had all the data together. But I think the emphasis on this as well, the private sector is voluntary. So it's voluntary choice by citizens to partake, private commercial arrangement, and the vast majority of that expenditure is with after-tax money. There's a small credit in terms of which equates now to roughly about 10 or 11%, so there's some small relief, but the vast majority of the expenditure is with post-tax money. Public sector is obviously funded through taxes generated by taxpayers and corporates, etc. The allocation then devolves through the Department of Health to the provinces and to the various health districts through the conditional grant and the provincial expenditure allocation, or share as it is. That gives an expenditure in public sector of 4.4% of GDP, or 223 billion. So the two sectors are very close in terms of size, although they do serve completely different population sizes. There are the 52 district health authorities in which the districts, if you like, in terms of which the public, the healthcare is then provided. We did exclude from this road accident fund and the compensation fund as a consideration. It might be included in there, but it's publicly funded, but almost all the delivery is actually in the private sector there. But in principle, the point here to look at is if we take this public sector expenditure and then allocate it across the uninsured population, you get an expenditure of 4,500, just over 4,500 per person per annum. And I'll just bear that number in mind because we'll come back to it just now in terms of comparing it to how it's going to come out in the NHI world. So the basis of the NHI proposal, just very broadly at high level, is that the expenditure that occurs in these two sectors can be put together into one pot, that being the NHI fund. And then we would have control of 8.5% of GDP. That was the desired number, by the way, in the white paper. Although the current expenditure between the two exceeds that, you'll see it's 9%. But we kept it at 8.5% because that's what the white paper, the green paper and the white papers both said. The proposal then is to remove the medical tax credits, which gives about another 26 billion, and to also remove the subsidy that the state provides to the employees currently for medical scheme participation, which amounts to about 35 billion. That then gives a pot there of 284 billion, or 5.6% of GDP. So the balance to get to 8.5% is another 2.9% of GDP, or 148 billion. And the proposal there is to raise dedicated NHI taxes from taxpayers to obviously make up that difference. Now, you know, fiscally, I've spoken to a number of economists who've all just balked at this number, saying it's just simply, even prior to COVID and the impact, it was out of the question that amount was going to be possible to raise. So I take it as there's not, although we live in strange times and I think stranger things may have happened, but let's see how it goes. But that then gives a pot of 432 billion. This is again still all in 2019 terms, by the way. And again, to come back, bring that down to a per capita number, the proposals of the NHI is to sideline medical schemes. Medical schemes won't be able to compete with the NHI So whatever the NHI fund covers in terms of medical cost expenditures, the medical schemes will not be able to do that. So therefore, those members that are in the private sector will be forced into the NHI fund. So if we divide that 432 billion now across the entire population, because that is what the proposal is, to bring the entire population into the NHI fund, we then get a per capita expenditure of 7,385, which is 64% higher than the current public sector per capita expenditure. So significant improvement in that budget. I thought this little cartoon might be apt in terms of how some taxpayers might feel about it, but anyway, I think it was courtesy of Dr. Jack who quite aptly put it there. But anyway, let's come back to this point now. The issue of whether or not those taxes can be raised is some very serious question. I think specifically now, after where we are now in terms economically, with the massive growth in debt, the economy stalling, massive unemployment, the prospects of raising that to me seem very, very slim. Might be an arguable or debatable fact, but let's leave that and accept that for the time being. We then left with 284 billion, which is basically the public sector budget plus those medical tax credits and the state subsidy, which gives, if presuming the proposal is still to make it a complementary system so that medical schemes can't compete, we then have a per capita budget of 4,855, which is only about 7.7% higher than the current public sector per capita budget, or expenditure, if you like. Now, I'm going to put a big red circle around that state subsidy aspect, because as we see it playing out now, you've seen the standoff that's sitting between the labour unions and government in terms of wage increases. Now, if the state's going to come along and say we're also going to take away that 35 billion rand subsidy, well, there might be question marks whether they're actually going to be able to achieve that funding. So if we scratch that out and say, okay, let's leave that, then what do we have left? So then that drops the NHI fund allocation to 249 billion, which on a per capita basis then says we've got 4,256 rand, which is actually 5.5% less than what the current public sector per capita health expenditure is. So you see how onerous this is all looking in terms of a lot of ifs and buts that are going to get to the hypothetical lot more money pot that the NHI proposals are all pretty much predicated on. So if we come back to this aspect of expenditure between the two sectors, currently in the private sector there are 9 million lives, 9 million citizens covered under medical schemes. If hypothetically that was a 50% better ratio and there were 13.5 million people on medical aid, the public health sector, the same public sector budget, so it hasn't changed in value, would then improve by 10% because it's obviously being divided by less people who are reliant on the public sector budget. So at no cost to government, it can improve its allocation quite handsomely if it facilitates a functional and efficient private sector, which is what we'll touch on just now in the health market inquiry, which should be done. So instead of having this controversial sort of antagonistic approach around the private sector, if it enhances the private sector so that it widens up to more citizens, it actually alleviates public budget and improves it without any more money being have to put into the public sector budget. So we've touched on the funding aspects now and how all of that is supposed to be rolled out, but the other aspects is obviously you can't have a health system unless you have providers who are delivering care. So again, I've split between private and public, and as I said earlier, it's in the private sector, it's either out-of-pocket or medical schemes that cover the vast majority of the expenses there. And in the public sector, obviously, it's the annual department's budget, the conditional grant, and the provincial equitable share. There is the aspect of the UPFS means test. I think on the surface of it, from what I see, there's not much being collected in terms of that. So I don't think there's much more money coming into the public sector on the basis of that. But if we then look at the proposal for providers, so we have the NHI fund, and then medical schemes will change their role from their current role to only being complementary. Sorry, I just need to take some water there for this throat. So the complementary aspect means that the medical schemes will only be able to cover non-NHI services. So whatever's not in the NHI package, they could cover. So that brings the private sectors or compels them in to contract with the NHI fund, specifically if those providers deliver services that the NHI is going to monopolize in terms of its structure. So if, say, for example, it's all dental work was going to be covered by the NHI fund, then dentists would have to contract with the NHI. There won't be a private sector for that, just to use that as an example. So, but we don't know what's in that package yet, so it's obviously very difficult to say how it's going to be impacted. But one of the committees within the NHI fund will be a pricing committee, which will then determine the remuneration levels to providers, both public and private. And we also have very little idea as to how that is going to pan out. But that will leave private sector providers then to contract with medical schemes, but only for the complementary package. Again, I say what that is we don't know, because the basket of care that the NHI is proposing is unknown. It hasn't yet been outlined as to what we propose on that. So there's a big question mark here, is what will this remuneration level be to both public and private sector in terms of delivery of care? Because if it's not realistic, if there's a force down in price to beyond what the private sector providers can sustain at, then we're facing another major problem, which is this one over here, the brain drain. And we can obviously ill afford to lose any more doctors, because at a national level, South Africa is short of doctors. As an example, when Cuba nationalized their health system, within a year they lost a third of all medical personnel that left the country. And health outcomes in Cuba suffered dramatically for about the next 10 years. It took them that long to catch up again in terms of outcomes, because the loss of doctors had such an impact on outcomes. So I think I want to touch here a little bit on some more philosophical points, the rationale of monopolies. So the NHI fund is a total monopoly. It will control the healthcare for all citizens, for whatever that basket of care eventually does pan out to be, but it will be on a monopolized basis. Medical schemes won't be able to compete, and citizens will not have a choice to opt out of the system. So here's Professor Michael Porter, Professor of Economics at Harvard. History tells us that monopolies that are truly benevolent and effective are rare. And he's a specialist in the healthcare industry, has been creating something called value-based competition on results. And the essence of it is you need competitive forces in healthcare to make them work. Monopolies don't work. Closer to home, one of our latest speakers, Professor van den Heever, the NHI bill proposes to centralize what should be decentralized. So this whole aspect of controlling every aspect of healthcare delivery, there are numerous international examples which show that a decentralized approach is much more effective in terms of improving outcomes and managing costs, for that matter. The purchasing function should not be placed within a national structure, as this distance from delivery will institutionalize massive inefficiencies. I do think he might have been kind in terms of saying massive inefficiencies. We probably have more the spectre of massive and rampant corruption, which is essentially what is most likely to happen in a structure like this. Lastly, on this point, one of my favorite authors, Nassim Taleb, who's considered to be, by many, to be one of the world's foremost thinkers on risk management. And he says here, we've lived since the dawn of modern times under the illusion that centralization is better, more efficient, and that large works better than the small. But the truth is that large public projects, under the myth of cost savings, incur disproportionately large cost overruns. Now, I can give you two homegrown examples, Medupi and Kusile. And I mean, they are years behind, and they are orders of magnitude over in terms of budget, because once you're in to such a big project, you can't extract, you're in. So it's the same with NHI. Once we build this, if it doesn't work, there's no alternative. So it's a huge risk, and I think this is the essence of what we're saying, is that if you tie everything to one horse, then if it doesn't work, if your horse doesn't win, you've lost it all. Competition in a competitive open environment is much, much better. The last point I'm going to touch, just in terms of finances, is this aspect here. Now this is, I think, from the Department of Health's point of view, the big white elephant in the room. This number has been growing at a ridiculous rate for the last 5-6 years. And it's now sitting at the last Auditor General report clarified this at 105 billion rand. Now, if we compare that, this last 2022 budget speech, the public health budget was 248 billion. So that liability for medical malpractice is sitting at 42% of the the total health budget. Now, obviously, that doesn't all get paid out at once. It does get paid out over time as awards, get awarded by the courts, however that comes. But the rate at which it's growing, we estimated that if it carries on at the same rate, by 2026, it'll be equal to more than 80% of the Department of Health's total budget. So this is almost like an Eskom debt problem to South Africa. This liability problem could be the same, because the only persons that are going to carry this are the taxpayers, just like we would be the taxpayers carrying the burden sitting inside an Eskom. And there's been very little in terms of addressing this issue other than to avoid the liability. Changing the rate of compensation, how it's done, etc., etc. But in terms of addressing the quality issues in the public sector, which obviously where these liabilities result from, there's really been virtually nothing to have been said about that. But the numbers are growing and very dramatically year on year. So just to wrap up in terms of this, I wanted to have a look at the health expenditure as a percentage of GDP between public and private across those other countries that we looked at earlier, the 25 countries. I did strip out Cuba because unfortunately it's such a massive outlier that it skewed all the numbers, so it is minus Cuba. But I want you to have a look at this is public health expenditure as a percentage of GDP on the blue bar, and the average is slightly under 4%. Now these are economies wealthier than ours. They also are developing economies, but as I showed in the example how we chose them, all of these countries have a per capita GDP that's higher than ours. South Africa wants to create a NHR which achieves a public health spend of 8.5% of GDP. It doesn't exist anywhere in the world. There is no such developing economy that has got that kind of expenditure in its health system. The green line is private health expenditure, including out-of-pocket, which we added there, and the average there sits at just over 3%. So I think this just to emphasize that the proposal to get public health expenditure to the level of 8.5% GDP is unprecedented anywhere in the world. I mean, we searched through every country we could find, can't find a developing economy at that level. So the last point I want to just discuss now before I wrap up is the alternative paths, and just at a very high level. And I think the emphasis to put here is that there is no real clear-cut path that we can say this is where we absolutely think this should go, because this is such a difficult and complex issue. The health systems are inherently massively complex, and when you're trying to marry how the private and public sectors work together, it adds an even deeper layer of complexity. So the point is, these are discussion points that I think that should have been brought into the policy process that have been sorely lacking, unfortunately, in a way. There's been a very absolutist stance from government from the very get-go. From 2009, NHR was the decided policy proposal. It wasn't that they went through a policy process and then said, what is the best solution? It was, this is the best solution, and let's just alter the policy process to make sure it fits with that. Which is why, by the way, a lot of the statements in the policy process don't stand up to scrutiny, for exactly that reason, because the policy had already been decided 12 years ago. So the private sector, we've had the health market inquiry spent 6 years gathering evidence, providing a blueprint to make the private sector more affordable, more efficient in terms of how it delivers, and in essence expand its cover base to a much larger portion of the population. As I showed earlier, the more the private sector expands, the better the public sector gets in terms of its budget because of the per capita allocation. Mandatory coverage, it was, for my part, slightly disappointing that the health market inquiry didn't recommend it, although they did state that it is in principle something that needs to be adhered to. Eventually at some stage it needs to come in, and their recommendations were to phase it in, which I do think is probably quite a reasonable and probably more mature response than trying to impose it all at once. But it's very important because the private sector suffered from massive cost increases because we have the social solidarity principles of open enrollment and community rating, but there's no protection for the medical schemes because members can anti-select the system by moving in and out of the system as and when they choose. Some ideas that we've sort of looked at is possible VAT exemptions on private health expenditure. You know, it used to be private medical services were not VAT exempt up until about the mid to late 90s, when VAT was then put directly on top of health expenses. So prior to that, there was no VAT on health because it was deemed a social good. But I think we could get to some extent of certainly bringing certain expenses to be VAT exempt, just as much as there is on certain food parcels. And we could look at the development of the low-cost benefit options, which has kind of revived again, but not really sure where it's going. But nonetheless, possibly that basket of services could be VAT exempt, which would then improve affordability to some extent around that. And also, we think in a medical subsidy rather than a medical tax credit. So the tax credit now, I think it's more progressive than what we used to have, but it still unfortunately only benefits those who are taxpayers. So if you're below the tax threshold, there's no advantage to the tax credit. And possibly you can convert that into a medical subsidy, which is given to the medical schemes to allocate to these low-cost benefit options, which would then make affordability a much improve the affordability of those products. If you add to that a lot of companies willing to subsidize products at this level, you really could get to a point of being a very affordable alternative low-cost package for many millions of South Africans. In the public sector, I mean, there's the spectre that has sort of emerged from the last year and a half a bit of the Zondo Commission. Obviously, it's rather depressing at times to sort of see the extent and breadth of what has happened and the corruption that's gone with it. But the public sector is no different. It has been fundamentally dismantled in terms of its capacity to deliver care because of this practice and the resultant malfeasance that comes with it, in terms of the corruption, in terms of unqualified people not sort of understanding what to do. I had a story the other day from somebody who'd visited a hospital, public hospital, to say trying to find the hospital manager, and somebody that he had to find to open the door, they found cobwebs in the hospital manager's office. He hasn't been there in however long it takes to develop cobwebs, I don't know, but certainly not a short space of time. So accountability is a key issue here. We've seen how the public sector budget is not out of line internationally. It has grown substantially in real and per capita terms for the last 20 years. We should be delivering much better healthcare. There should be better outcomes there than what is achieved. And can only be a lack of accountability that is avoiding that issue. And that, I think, will come from leadership, getting the right leadership into the key positions in the department, coming right from the top and getting that fixed so that we have better outcomes, that people actually can rely on the public sector comfortably. Raise this as a question mark. We had a health market inquiry for the private sector. Do we need one for the public sector? Do we actually all know what's going on in the public sector to the extent of the problems that are besetting it? The outcomes we can see are obvious. There are problems there. We need to, how do we address them? Maybe we don't know. Maybe there are answers to that. And maybe it can get to the point where the public sector, if it can build up its capacity, build up its skill, and be delivering good outcomes, it could actually be competition for the private sector, which if we have two efficient and functioning sectors competing with each other, we all know what happens when that happens. Costs go down, quality improves. But at the moment, the private sector can operate completely on its own. It's got no challenges from anyone. Anyway, that's it from me today. Thank you very much. I believe Patrick Bracher will be speaking up next. Thank you very much for your time.
I've spent the last few days reading the presentations that were made at the Parliamentary Health Committee on the National Health Bill, and it becomes quite an extraordinary read because there are presentations from all sorts of health professionals, all sorts of bodies. And what happens is that if anybody says anything negative, then you get immediately accused of not wanting to give health care to the poor. I mean, it comes out, they actually minutes of the meeting, pages and pages of minutes, you see what people actually say. And I always start these speeches by saying that none of us believe that. Nobody in this room believes that, and Mike has just shown with inexorable logic that that is not the position, that there are people sponsoring healthcare to a very high degree in this country. And I personally wouldn't mind if you substituted a very efficient system for my medical scheme. If you had the delivery and you charged me about the same, I wouldn't mind. And we don't mind public health care. And we don't mind getting proper services. And what Mike doesn't touch on, because it's more statistical, but if you take just the general expenditure on health, sorry, I've just done something I shouldn't have done. If you take the general expenditure on health, I mean, they made the point some years ago, I don't know if I'm old enough to remember Ivan Illich. You might remember he was a sort of pop philosopher in the 60s and 70s. And he said, you know, if you took, it was in the days of Chris Barnard and the heart transplants, he said, if you took the money that was spent on heart transplants for a few people to survive and you put it into clean water in rural areas, you would save X number of children, you see. So it's a way of dividing it up. And you've seen what Mike has said. I mean, I wish, Mike, that you would go, if you dare, to the health committee and put this logic before them, because it just stands out, doesn't it? I mean, you move the expenditure, you could even improve the expenditure, and I'll come to how we go about that. And I bring my constitution. I always say this is my very favorite book. You know, you'll see it's falling apart because it's a remarkable book, and it does us proud. It really does. I'm not giving you that speech about we've got the best Bill of Rights in the world. We have, but that's not the point. It's just it's a very workable constitution. And the first principle is, and it's a very important principle, is that we what's called a consultative democracy. And don't underestimate that. It says it in the Constitution that it's a core, it says it that in section 59 and 72, the National Assembly, and these are words out of the Constitution, must facilitate public involvement in the legislative process. And we do that. I mean, we've got the committee sitting in Parliament now. They've sat for 3 days listening to anybody who wanted to pop up. But there was the land access movement in the Constitutional Court said that the public must be afforded a meaningful chance of participating in the legislative process. Now, what happened there, if you remember, that the land problem became difficult because in 1998 they cut off, you had to put in your claims by 1998, and if you didn't, then you didn't have a land claim. And then they found there were thousands of people who had land claims who wanted to pop up afterwards. And they passed a law saying, well, now we're extending the date. And the people who put in the earlier claims went forward and said, you've interfered with my right. I've been around since 1998 trying to pursue my rights. And now you're putting a whole layer of people on top of me, and often for the same land, because people say, this is my land, this is your land. And what happened, it was pushed through Parliament in a very short space of time. They had a sort of pretense of public engagement. It was all done in about 30 days, and the Constitutional Court said that is not consultative democracy. You've got to give people a meaningful chance to participate, which means a meaningful time to get. Now we've had that in this country, and what they did, and funnily enough, it's quite ironic, isn't it, that in this very week we know that the consultative process was a corrupt thing. The very first step of this law was this digital company which went around to publicize, among other things, national health. So that was the very starting point. They went around, the Department of Health went around, it's the right thing to do. They went around the country and they called meetings, and the population came there. If you remember those things on TV, there were halls full of people, and that's exactly what you would expect, because if you go to any public hospital on a Monday morning, it's a depressing sight, isn't it? You just see queues of sad people sitting in rows and extending out into the parking lot, hoping that something will happen. Those people rightly and understandably went to the public process, they went to the public meetings, and they were invited to make submissions. They made submissions. Some of you may have made submissions. They got about 3,400 hand-delivered submissions, and they got about an equal number of emails. So now you've got 7,000 people. I'm sure most of them said, yes, we really need public health. I doubt whether they were Mike Settas' analysis of the situation. But that's understandable, and they, at the last count, they hadn't started, they'd read about 20% of them, I think. But I don't think it matters, because the people had the opportunity. But the difficulty is this, and Mike has touched on it. If you have a public process and you say to people, please come and tell me what you think about the system, it doesn't work if it's an umbrella bit of legislation such as the National Health Insurance Bill is. Because Mike said, you don't know how the contract with the doctors is going to work. You don't know what the pricing committee is going to say, what the maximum you can charge to do root canal treatment. So you don't know. So you can't comment if you're a dental surgeon. You don't even know what is in that formulary. They've got to do a formulary and say, this is the treatment you can get from the National Health Insurance System. So, and over and above that, you either pay for it yourself, or the complementary role of the medical schemes will come into play, and you can go and get your medical scheme to pay for it. But when they're taking your money, and I'll show you how much is going to be taken out of the pockets of people, when they've taken your money, you've got to find money somewhere else. You can't go to the parliamentary committee now or to the town hall in Rustenburg and make your submissions, because you don't know what's in that bill. I make the point there that if you look at the regulations section right at the end of the bill, there's about a page and a half of this Government Gazette of 28 different things that need to be regulated. And they include things like the legal relationships. Now that means a bunch of legal relationships, because every medical healthcare provider in this country has to have a priced, negotiated contract to say, I will do your heart transplant. That may be sort of an exaggerated thing. I will do your root canal treatment, say, for this price, and there's got to be a contract. Now that, I don't know how many people are going to go out and negotiate. It says negotiate the contract, so it's not just a matter of sort of settling it down. You've got to go and talk to somebody. And then you've got to have a legal relationship with every one of us. Last count is at 58 million people, I think, is what we currently say our population is. 58 million people have to register with their biometrics, their photograph, everything. So it's a massive problem. The formulary still has to be done, and how you get accredited gets done. So it's a huge problem that is not stated, because it's going to come in a regulation which is in the mind of whoever the Minister of Health happens to be in that time. And while I'm using the word time, you know, I've shared platforms with Dr. Nicholas Crisp, who speaks on behalf of the Minister. And the first one was very optimistic. And if you remember, the President came out and said at one stage, 2025 it would be in place. That was just a nice little political statement. But the last time I was on a platform some months ago with Dr. Crisp, he said, well, he doesn't know, and he's much younger than me. He said, I'm not sure it'll be in my lifetime. It's maybe 10 to 15 years. So, you know, that's what you're talking about here. It's not just something that you can just do overnight. But the problem, the last time I heard Alex van der Heever, he said, well, that's the problem, you see, because you can't roll out national health, because you can't have it in the Eastern Cape and not in Limpopo, because you're doing it progressively, because you can't have sort of some of the people on a national system taking budget money to spend on a province. So how do you actually get it into order? Now, I'm sure you all know Section 27. It's one of those beautifully brief things in the Bill of Rights. Everyone has the right to have access to healthcare services. And Mike has produced figures to show that on that international scale, we're not doing badly at all about the access to services if they were working adequately and not being, I heard somebody on the radio use the word yesterday, looted. And this wasn't a white monopoly capitalist either. It was just somebody talking with inside knowledge of what happens in hospitals. Now the state, this is Section 27 goes on to say, the state must, I've underlined on purpose, reasonable legislative measures within its available resources to achieve progressive realization of this right. Now let's just start with progressive realization, you see, because you can't say I'm giving progressive realization to the right if you take away my medical scheme membership and take my money from that and my money from tax, and I haven't got a healthcare system in place anymore. You've got to sort of develop it from the bottom up, and I'll come back to the other point on that is further down. And then, of course, available resources. Mike has given you figures. I mean, we're already spending 8.5% of individual and government resources on something which isn't working very well, except in the private sector. And I'll deal with the available resources and how they are tackled and how they are taken. Now, Mike had some figures there. The process began in 1994. That was the first date I could find. The first white paper, according to the Health Committee, said 1998, and that was when the Medical Schemes Act came in as well. But this has been going forever, and Alex has got a lot of statistics last time I listened to him about how this process has been going since the early 1990s, this imagination for a national health system, which is a good idea, but it hasn't happened in 30 years or more. Now, the next point is that magic term at the end there, health system strengthening interventions. They call it an HSSI. Everything gets acronymed these days if there is such a verb. Now, what that means is that you are, as a first step, and this is at the beginning of the section in the National Health Insurance Bill, it says before you start anything, you must do health system strengthening interventions. And that is a long thing for saying, make your existing system better. Make your hospitals work before you put them into the national health system. And if you look at what has happened in every appropriation bill, there's an item for health system strengthening interventions, and it's a small amount of money that they've allocated every year up to now. Because, as Mike said, 102 billion has to be reserved for medical negligence claims. And of course it's a bad process, because what happens is this: every time there's a judgment in the Eastern Cape for a child who's born with cerebral palsy because of a birth defect blamed on the hospital, every time there's a 30 million, and this is the kind of figures that these judgments have, because you have to pay for the health care for a cerebral palsy child for life, 30 million, 25, 30 million per claim. Every time that has to be paid out, it has to come from somewhere, and Mike showed the figures. Out of 240, you need 102 eventually. Now that money, where does that money come from? It comes from not buying the new cancer machine. It comes from not having the new systems in the hospital. It comes from bedding and food, because it's the same money, it's the same pot. There isn't an insurance system out there with reserves to pay claims. So it's a badly fulfilling incident. Every time you have a claim for 30 million, you probably get another claim because there aren't enough people in the obstetrics department, or some machine is missing, or somebody is emigrated or whatever, because there just isn't there. So that's why, I mean, your figure, Mike, you say it's going to go up. It has to go up, because you take from where you need the money for healthcare, and you put it into one claim for one bit of litigation, and it's not working. Now, I'll come back to available resources because it's a big discussion. And I say it's not a health issue, it's a money issue. And that I think you've seen from the previous slides that you saw. Mike, I really enjoyed them, by the way. I really thought it was sort of just putting it out there, just absolutely, I like logic. So when it all adds up that way, and it's not an emotional thing, it's not anything, it's just there it is. And that's why next time the committee sits in Cape Town, maybe you'll go with a mask on and pretend. Now, the first thing I want to say is that it's competent for Parliament to pass this law. When I first looked at it, I thought, well, is it? Because healthcare is a national issue and healthcare is a provincial issue. If you look at Schedule 4 of the Constitution, it says what the provinces do and what the national government does. And the provinces do healthcare, of course. We know that is provincial hospitals, is this term, and I'm not sure it's still used. So it's within the functional area of concurrent national, provincial, legislative competence. That's a real lawyer speaking, isn't it? All those 4-syllable words in a row. But it is a functional area for concurrent legislation. In other words, the national parliament can override the provincial parliaments in order to pass this act. Because if you look at the next bullet, it says it's a matter requires uniformity across the nation, and Section 146 says that if it's something that requires a uniform system nationally, it's Parliament's job and not the province's job. And it can be regulated by national legislation. The Parliament will pass it, then it'll go to the National Council of Provinces. Now, what would happen there is that each province would have its say. And the say is quite important because if, as I will show you later, they take provincial money to put into the national health scheme, the provinces should be complaining. And I suppose the Western Cape will be complaining because they're on the other side of the fence from the government. But there's no doubt about that. But because there's a majority of the governing party, it will go through the National Council of Provinces. And one doesn't mind the fact that national health laws go through, but do we want this law? So the problem is this thing about uniformity across the nation, because what uniformity do you get? Because as I mentioned a little bit earlier, there's different provincial areas, and in different states, Eastern Cape has got a pile of these judgments and running on negative. Western Cape does much better. Other provinces are falling apart or not falling apart, but the quality of healthcare services is different. And you can't just unplug what we've got now, as Mike said, and plug in national health and it starts up the next day, because it's a provincial, regional, local thing that you have to keep doing. And so you can have the legislative competence, but you can't interfere with provinces as easily as this bill suggests. And I'll tell you more about that just now in regard to the money issue. Now, in the parliamentary submissions that were made in the last couple of weeks, they quote the state law advisor saying that this is not a money bill. Now, look at the second bullet. A money bill is a bill which appropriates money, imposes national taxes, levies, duties or surcharges, or authorizes direct charges against the National Revenue Fund. The state law advisor said this national health bill, if we put it through Parliament, is not a money bill because it deals with administrative things, and therefore it doesn't have to have a money bill. And if I could just find it for you, I hope one of these flags is the right one. But when I get later to the point about sources of funding, it says general tax revenue, reallocation of tax from those subsidies, payroll tax, a surcharge, and there's the upfront contribution. Now those are exactly the words that Section 77 uses. So you cannot say that this is not a money bill. And it's also a money bill because it requires a massive input into the coffers of national health from day one, because if you've got to register 58 million people on a system, and if you've got to have a signed contract with every healthcare provider in South Africa, nobody has said what that will cost. And it must be a grand fortune that's going to go into administrative fees. Mike, I don't think your figures even deal with that. I mean, there's a huge cost of just getting this thing going. And of course, there's going to be a bit of leakage as well. But just to get this going, to sign up, and who's going to do that? Who's going to sign up 58 million people on a system because they haven't got any choice, because you can't get healthcare elsewhere? Now, it's going to be progressive, obviously, but it's not built into this, and it's not an administrative bill. It is a money bill, which means, you see my last bullet, only the Minister of Finance can introduce a money bill, and we haven't heard from the Minister of Finance. There have been a few broad general statements, but I haven't heard anything from the Finance Department saying what their view is on all this money that has to be sucked out of the general coffer into the system. And Mike made the very important point. He says, once you've put all your money on the one horse and you can't stop it running, or you can't stop the race and say, no, I'm losing here, so slow down, please, because it's all just rolling out. And the money is now flowing into something which has an ongoing total cost. You've got to give health care on the formulary to the entire population. So you can't stop, and I'll come back to the problems that that introduces. Now, coming up very shortly is the Appropriation Act. You'll know what happens in our fiscal system. The Minister of Finance has the budget speech. And it's a general, broad budget speech saying, this is what I'm going to do, and this is where I'm going to emphasize, and I need more money for the police, I need a lot of money for COVID, etc. And then that gets translated into the appropriation bill, which gets down to those kind of figures that Mike gave us. That's when you say, how much do I appropriate for X, Y, and Z? And that is a process that has to go through Parliament, and I'll come back to what this Act says about it. But it says, the bottom bullet there, the money will be appropriated unconstitutionally because it includes shifting of funds from the provincial equitable share. That's a quote from the bill. Now, what happens is this, you get together, and the Constitution says each province has to have an equitable share of the national income. When we all pay our income tax and all the other taxes, VAT, etc., and it's all in the national treasury, the provinces have to get an equitable share. And Mike, what was your figure? It was 300 billion, I suppose, somewhere like that. Now, you can't shift that money because, you see, you can't say, well, I've now established a national health insurance system and I need a lot of money for it, so I'm going to shift the money out, because that money is being used to pay for the provincial hospitals, for instance. So you can't suck it out of the hospitals and then put it into a system of insurance when the hospital is no longer operating properly, because you've taken the money away from the province that they used to spend on bedding, food and medicines and machines. So it's not something that you can do constitutionally to shift the equitable share, because it's a national thing, national health insurance bill, and you can't take provincial equitable share, and the Constitution is absolutely clear, give them what equity requires them to run that province, and in our context, run, for instance, provincial hospitals and provincial health systems. Now, the Appropriation Act can only be done by Parliament, and that equitable division is done. And now, imagine the situation when you have the equitable division. We've just seen it in stark reality, and that was whatever plans the Minister of Finance may have had last year, a whole lot of money had to go into the the COVID pandemic. So things happen where you have to shift your focus every now and again, which I will return to. And the provincial allocation, I said last allocation was about 500 billion if you total it all up, all the different components of that. And you can't just suck that out of the provincial system and hope things will work. The different purposes for that is the provinces put in their budget every year and they say, I need so much for this and so much for that, and then I will use that money and you have to allocate it towards me. And we have a whole debate in Parliament. It's not really a debate, you know. Modern parliaments, and I'm not talking about South Africa only, life is so complicated these days that what happens in Parliament is, on the floor of Parliament, they don't look at the finer detail of appropriation, how much do we need. They look at a broad principle and say, look, crime has gone up, we need more for police. But you see this, as I say in the bottom there, when it said it's got to be a progressive realization under Section 27, it's not a progressive realization, because you can't just shift the same money around and say, well, I'm now progressing forward because I want to give healthcare to the total population, if you're taking away what the provinces are doing with your money. Now this is the whole key to it. The money must be appropriated from money collected in accordance with social solidarity. Mike used that phrase, and social solidarity means that the wealthier people have to sponsor those who are not well off. And that's an international system, that's the way tax works, and that's why higher earners pay more tax than lower earners. But it becomes an excuse in this bill, and that is where you get into this debate every time you go and talk about the National Health Bill, saying, well, you don't believe in healthcare for the poor because you don't believe in social solidarity, which Mike's figures dispute. Now, this is the source of funding. Firstly, they want to reallocate the current medical scheme tax credits for medical scheme members currently. Now that's perfectly in order. That's a tax rebate that we get on our medical scheme. The Minister of Finance is perfectly entitled any day, any expropriation, any budget to say, I'm going to take away that credit. It's been fiddled with over the years. So that's a completely legitimate way. But that, Mike, what is that, about 30 billion? I think it's in that kind of region. So it's not going to solve the problems. The next one is the bill imposes a payroll tax, and you'll know that the national skills levy is a payroll tax. And we have other payroll taxes like UIF. It's a little bit that they take off in order to fund a specific thing. Now that's fine in the context of skills levies and UIF, but when you get into this kind of money that you need here, it's unheard of to take a payroll tax out of people's pocket in addition to everything else to fund a specific system of government solutions. The next one is a surcharge. It's also been called a levy on personal income tax. Now, the bill says that this is where the money comes from, all these things. But it's unique in my experience for you. It's not unique, but it's unusual except in sort of wartime and other times to say, I'm going to put a surcharge on your income tax. You have to pay another 10% because I want you to pay for the National Health Insurance Bill. It cuts across the whole constitutional framework because the minister is supposed to decide year on year what money is needed for different things. So you can't just say, I'm going to put a surcharge, and the Public Finance Management Act and the Constitution does not allow you to say, I'm putting this block of money aside legislatively for health only. And I don't care what happens in the future. If there's a need for more policing, if there's a need for more education, tough luck, because this is a surcharge for health only. I want to take that money specifically. And it's not what the Public Finance Management Act says. And the two things that override the National Health Bill are the Constitution and the Public Finance Management Act. It says so in Section 3, I think. So, and where's the Minister of Finance in all this? And I say there, what about police education? What happens if you have a drought or major some other major disaster, some terrible cyclone in KwaZulu-Natal. I don't wish it on KwaZulu-Natal people who are listening to this broadcast, but I'm just giving an example. But I mean, you just saw in Australia now those massive fires. They've had a special levy there on insurance companies. Incidentally, they're proposing to increase the tax on insurance policies to pay for some of the public services that are provided. But you see, in 5 years' time, when we've got this whole system up and running and it needs a huge blob of money, and the Minister of Finance says, no, but education has fallen behind. We've got all these unemployed people, and I need another 40% for education. You can't say, well, sorry, it's all been taken. Education just falls apart, because then you just got one national health bill which overrides all sorts of other requirements. And then they say that they will get the fines. Now that's an extraordinary thing, because then you have a terrible situation. If the people who are fining you get the money for the fines, imagine if every time you went to the magistrate's court and there was a discretion about your speeding fine and the money went to the magistrate, your fines are going to go up. There's no doubt about it. At the moment, that's not the system. If you get a major penalty, I mean, you can 10% of your budget as a private company if you contravene the Competition Act. That doesn't go to the Competition Commission. It goes to the National Revenue Fund, and then that's part of the Minister of Finance's funds to allocate to education, drought, health, etc. So it's not something that you can allow the person to be the judge, jury, and beneficiary of a fine. So that's also an extraordinary new step. And this is all on top of what, right at the beginning of the Act, they call a mandatory prepayment in accordance with income levels. And that means that when you go for national health, you've got to have a prepayment which will be according to your income. So therefore, on top of your extra tax that you pay according to your income, the extra surcharge that will go on top of that, and all the other things, your prepayment for health services is going to be adjusted. There's nothing wrong with that in principle, you see, because that is social solidarity. But we don't know what it is, because it's just one line in the definition section of the National Health Bill. So when you talk about a consultative democracy, I can't put in a submission saying, well, I don't like it because 10% is too much, or whatever the case may be. It's just a line in the legislation. The other thing that happens is that treatment can be denied, and this is some of the things in Section 7. It says there's no medical necessity according to the practitioner. And you go there and you say, and probably a good example, I want my breasts reduced because it's giving me back pain. And the doctor says, no, you just want it for cosmetic reasons. I don't think it's medically necessary. Your back's not that sore. And then you go out, and then what do? All the people are contracted in. You've got to go and find a private doctor at your expense to go and get the operation done. Then if there's no cost-effective intervention according to a health technology assessment, and you can do a search on this bill, you won't find out what a health technology assessment is. But you have these debates with the medical schemes at the moment. They have these enormously expensive cancer drugs, for instance, 200,000 rand a dose, and there's always a battle about whether it's cost-effective. And some health technology assessment will be done to say, no, that particular treatment for cancer is too expensive and I don't think it's working very well. I suppose it's like the kind of ivermectin debate. Does it work or doesn't it? Although that's at least a cheap drug. But somebody's going to say, no, this is not cost effective. You can't have that drug. Tough luck, you go and pay the 200,000 rand yourself. And if it's not included in the formulary, which we haven't seen a clue about what it will be in and what will be out. I presume most things will be in, like medical schemes, but we don't know. And then you pay on your own. You're not entitled to the services, and if you don't comply with referral pathways. Now, I presume what referral pathways means, if I've got a pain in my chest and I don't go to my GP because I know the heart surgeon very well, and I don't go through the referral pathway, they won't pay for my consultation with the specialist because I didn't go through the process. So there are lots of ways in which we may not get medical care out of all the expenditure which are not on paper already. Now, the final thing I want to say, I'm not sure it's the final, yes, it's the final thing. The healthcare service providers are not obliged to register, but it's going to be, it's one of those, it's not exactly voluntary consent, is it? Because if you're not going to get any patients if you're not registered. But I presume that somebody is a top specialist in heart surgery who's got a big enough private practice and enough wealthy people to come and support the lifestyle and the huge money they pay for insurance, then you could say, look, I'm not registering in the system. I'm a Harley Street specialist in the English example, and I've got enough of a client base, patient base to not be in your system. That is perfectly possible. And Section 22 says everybody has the right to choose their trade, occupation or profession, which can be legislated, but I mean, somebody doesn't want to go into the system and thinks they're going to survive anyway. They can do that. So it's not necessary that every doctor will be on. So my closing remarks, let me just sum it up. It's not a proper consultative system. It's not constitutional in relation to the way in which the proposal is to take money for this very expensive concept. And then, I was really struck, Mike, by your statement, which was this, and Chris, also your opening, you had some sort of alternatives. I mean, what you need here, to me, is, yes, have that, but don't have it exclusively. I mean, if you say, well, I'm going to set up a national health system because I'm going to do some sort of insurance, but it doesn't have to be compulsory. You don't have to do away with medical schemes. You saw the health professional people in Parliament this week saying, take away the reserves, take away my private savings account with my medical scheme, take away all that money and put it in the system. Well, that's just a one-off and it's not going to work. So you can have this, and I think the health inquiry did that, didn't it, Mike? They said, well, you don't have to have one or the other. You can have both because it's working. I mean, Mike showed us it's working. So give us national health if you think it's going to work. Mike's figures and commentary from around the world show that we're not behind. We're just behind in the quality of care that we provide. So that's the summary. I mean, it's mostly constitutional in concept, but in practice, it really doesn't work. And they've got to start again. I mean, Alex, last time I heard you said some rude things about scrapping it and starting again, which maybe you'll say again after me. So I'll leave that to you. But it doesn't work from a constitutional point of view. It doesn't work from a fiscal point of view, in my opinion. And it's not doing anything proud. And it's become it's exactly like the amendment to Section 25 of the Constitution on expropriation without compensation. It's really more of a political issue than a health issue or a land issue. And you can't back down. That's why you go to public meetings and say, I'm going to give you national health by 2025. It's not achievable, and it's not achievable legally, and it's not achievable practically. Thank you.
Okay, good morning. So what I'm going to sort of give a presentation on are some of the universal health coverage alternative considerations that really emanate not only from my work, but also from policy processes, which some of you may be aware of and many people might not be. If you look back in time, we actually haven't had one coherent set of proposals for health reform operating continuously since '94. You have some attempts in some of the public comments from the Department of Health and from the sort of the political side of these proposals, who try to go back to like 1941 or something along those lines and say that there's some history to NHI proposals all the way from that period. That is complete nonsense. All of the health reforms at different periods are very much informed by the conditions of the health system at the time. And probably one of the largest sort of systematic set of reforms were proposed in, it came out of a commission a Gluckman Commission in the sort of 1940s, which tried to mimic, because of the proximity between Smuts and the British government and the relationship to Churchill, who saw what was going on with the processes that they had initiated with Beveridge in Cabinet, to create basically a post-war world in which you didn't create incentives for people to support Nazis or Stalins. And so they were thinking very carefully about trying to create a fairer society. And while the War Cabinet was continuing in the United Kingdom, you had what was essentially the preparation of a welfare state in the United Kingdom, which was then implemented by the subsequent government, but it was a War Cabinet, so you had different parties in the same government. And so Beveridge fell under the sort of the Labour Party type of direction, basically then implemented the white papers that were developed during the period of the war under a different government. And there was a large degree of consensus around those reforms, and it set up the NHS. So South Africa, you know, Smuts is hanging around there. Not sure why, but he was. And he set up basically a similar process back in South Africa, where Gluckman tried to look at how our healthcare reforms should be restructured, and he came up with the National Health Service idea and some restructuring. And but then the government changed in 1948, and basically most of those plans were shelved. And the issue was, when you go through them, technically they're relatively shallow. From a structural and a systems point of view, but it's not unexpected for the period, because people don't really know a lot about health systems then. Very few people had any idea of insurance systems. In fact, health systems themselves, the NHS becoming one sort of point of departure internationally, where people try to conceptualize a new health system as part of a single process. Most other countries have allowed their health systems to evolve. So, for instance, the UK was on a pathway not inconsistent with much of Europe, which had medical schemes. And a lot of countries in Europe basically created the national health systems out of an evolution of the establishment of frameworks around insurance-based systems. So they're typically referred to as social health insurance systems, but they're very often multi-fund systems, but regulated. The Netherlands, Belgium, a version of it in France, etc. Most of the countries actually fall into that. You don't really have the NHS type model except in very, very small number of countries, and certainly not to the extent of attempted centralisation that you had in the NHS. It doesn't mean that the NHS wasn't a successful intervention for its time and for its type of country and its context, which was more appropriate for which had a unitary government and a very small country size to deal with. So just pointing that out, because this idea of some kind of coherent evolutionary thinking process behind what has been tabled in the National Health Insurance Bill is essentially not true. And it is a deception and is not accurate, and it does need to be sort of properly debunked. There is a history to the evolution of the health system, but it's largely chaotic. And if we look at the post-94 period, we actually have, I've actually written, you'll see some of it in the sort of NHI bill review that I've published, but also published in Health Policy internationally on South Africa's reform pathways and alternatives. And in essence, there have been two kind of broad strands to a reform framework that moved forward. One which basically acknowledged our current system as a starting point and looked at basically stabilizing the regulatory framework for medical schemes as an historical system that can be built on, and where its role in a universal health coverage model can be strengthened using the assets that it has evolved over time. And the other part being how you would regulate the state itself as another part of our combined system, and how you would harmonize the two. So that's the one model. And in fact, the Taylor Committee of Inquiry in 2002 referred to that as an NHI model. But it's not a single payer NHI model. It's a multiple payer model, which accepts, as in many countries, a pluralistic health system which must hang together in order to function well. The NHI proposals emerged out of Polokwane in 2007 and were largely a political proposal, a one-liner. NHI must be implemented through a reform of the public health system, something along those lines. Really not very well thought through, absolutely no research behind it, nothing beyond that line. And since that period, it has been very much, and it was very much part of the political deal that got Zuma into power, because you had a number of constituencies that were quite important to establishing who would be president. And we're seeing the consequences of a lot of that, because the power around the president is immense. And it's a very, very dangerous post. It's very dangerous, given that the powers of the president to influence systems of meta-governance can influence whether or not the government and the state can function. Just on the president alone, you can destroy many of the systems of meta-governance, as we've seen. And to repair them potentially require some structural reform, which we're not seeing. So we remain at risk at that level. So the battles around who gets to be president are very important. And there are lots of moneyed factions around that. So it's a transactional process. It's not about equity. It's not about achieving harmony in South African society. It's about who can access tenders, who can access licensing arrangements and make deals, who can basically access the systems of patronage using the authority of the state for their own private reasons. And we see this in many kinds of reforms as well that we have, is that you will notice there's a consistent model that is always proposed, not just in healthcare but everywhere else, where the idea is that using the authority of the state, you establish a state monopoly structure and you prohibit competition to it. So you actually actively prevent somebody else from competing, because that protects a structure that doesn't have to perform. So it's the equivalent now, if we had to go backwards, to say Telkom becomes the only supplier of telecommunications in South Africa and everybody else is banned. And of course then you're pretty much stuck with whatever they do. And then a lot of time is spent legitimizing that. We see the problem with Eskom. Eskom is the same. So the issue of this threshold, the 10,000 megawatt threshold, is an equivalent. It's basically saying there's a fear of competition, because in fact if we did want to eliminate our supply constraints in South Africa, you would just lift that threshold and you would watch the production come in. It would just come into the system. You wouldn't have a constraint. So our constraint is largely structural through the way in which our centralized structures are directed in order to foster patronage interests. Because if you're the gatekeeper of such immense power through the concentration, it essentially means that you don't have to do your job very well. That's not really important. The question is whether you can enrich yourself and a particular elite as a consequence. So we see it also in food parcel distribution, prohibiting gift of the givers from giving out food parcels so that state structures can be seen to be the only ones allocating them. The attempt now to preserve the post office by making it the monopoly supplier of all parcels below a certain size. Why would you do that? The only reason you would do it is to protect a totally inefficient public entity whose purpose is drifting from any concept of public value. And this is the danger in these designs, is that they are not designed with a coherent public purpose. They are designed, and they're not designed in order to deepen public value. They are designed in order to strengthen patronage networks. And that's where one has to be incredibly careful. When I look at the NHI bill, the last draft, the draft that's out there that I evaluate in this report, is so poorly conceived. The actual quality is so poor. If I were to design a single-payer NHI system and create a plausible bill around it, it wouldn't even be that bill. So even with the same intent, I wouldn't create this garbage. It is such nonsense, the bill as structured. And I'll just make one or two comments on what Patrick has mentioned before, including references to the revenue sources to this fund, shows complete ignorance of how the state operates. Yeah, it would convert it into a money bill if those sections actually had any legal effect, which they don't, because it's not a money bill, which means that they mean nothing. They're just kind of advisories to somebody else that we can receive revenue from these sources. But you don't have to put that in a bill. You can put that in a policy paper or somewhere else. All you have to do in a bill like this is to say that this fund can receive appropriations from the state. That's all you have to say. The rest is up to the other parts of the state. How you design your revenue raising system for the state is up to the state. You don't put it in a bill. So it can't actually create its own revenue sources through a bill. That shows ignorance. The way that they've designed many parts of the bill through how they would operate various entities that they would establish for purchasing are just nonsense and shows even ignorance of the Public Service Act. So I think that the bill as it stands now certainly cannot be implemented, and in discussions I've had with the various people responsible for this, they're clearly acknowledging that this is a dog's breakfast and they clearly want to clean it up. So the first issue is that after 11 years of some sort of government process, to come up with a dog's breakfast as a piece of legislation is indicative of the quality of thinking behind this policy framework, and suggests that there really isn't much. There is also no analytical framework that supports both the rational aspects of the bill as well as its reasonableness, which are clearly important from a constitutional perspective where you are taking people's rights away in this bill. So the reasonableness tests that would be asserted in this framework are required that you've done. There's no underlying work that is being done to show why this has a coherent public purpose. And the problem is when you read through that bill, I could spend 100 years writing stuff on just how stupid the bill is, and it's just a waste of time because it's never ever going to be implemented as such. So, but the point is, where does this leave us as a process? It means that we do have to look at the alternatives. And I just wanted to make one or two just quick comments that Patrick kind of sort of raised that I think are worth noting. On medico-legal claims, I mean, I look at this quite intensively. The contingent liability runs into the sort of 150 or so billion rand. Contingent liabilities aren't what the state pays. Those are matters that are yet to go to court. The actual amounts that are paid out every year, the amount of actual paid out claims that amount to roughly about 1.2% of overall expenditure, which really isn't a great deal. What's interesting is that that's what, say, Hattingh would be paying out, but the Western Cape only pays out 0.3% of its budget, which shows they run their services better. They're not actually creating cerebral palsy children at an industrial scale as they're doing in the other provinces. So the issue is the clinical governance structures in much of our provincial health system are non-existent. And in many cases, I mean, there's so much to say just on that issue. What's it telling us about the systems that are in operation in our public services? There is no review of those cases because they want to defend them. So they want to say, we're not negligent. So they don't investigate them as negligence, and they don't fire the CEO who's responsible for what must be a systematic failure within that particular hospital. So what they do is they just allow the services to continue as they are. So where is the consequence to failure at a clinical level that is systematically resulting in the failure of these labour wards and the services that are immensely important to mothers and children. So the maternal mortality ratios in South Africa match what we're seeing. We're over 4 times the level of maternal mortality deaths in South Africa in the public system than we are in benchmark countries to South Africa. So where they might have 44 maternal mortality deaths per 100,000 live births, in that's comparative countries to South Africa, your Chiles, your Brazils, your Argentinas, etc. South Africa has over 130. Which shows that on an outcome indicator, we are a subpar performer deluxe. And that is a consequence of how we're managing those services, not our resources, because we're actually spending more than those countries on our public system. So there are a lot of things that need to be investigated very carefully in our system, and we need to be focusing on how we address those flaws and faults. So I'm going to run through, but I did note again, just on a quality check, given the trouble that the Minister of Health is in at the moment, on whoever writes his budget speeches and things like that. I did notice that in the budget speech, when they referred to the medico-legal claims, instead of saying 130 billion rand, they said 130 million rand in contingent liabilities. They said these are huge amounts that the state can't afford. 130 million. That's roughly what they've paid for, digital vibes. So I think I think it's worth actually looking systematically at the historical reforms in South Africa, because in fact quite a lot of policy work has gone into these. And one of the latest processes has been the health market inquiry. And these are actually not part of a single coherent process in government. So as I pointed out, I've got the references if anybody's interested in actually reading the underlying reports. So I think the first issue is just to talk about our context. We have kind of two systems. Somehow it's interesting how many fires do affect the public health system. But a point about it, again, you kind of look at proxy indicators of what's going on overall within the health system. And the public buildings in a health system are actually run by a separate department. The maintenance and the investments are run by works departments. In the Hattingh Department of Health would be the Department of Infrastructural Development. And what tends to happen is that they top slice all the money for maintenance of buildings. It goes to this department and appears to disappear into a black hole. And the hospitals have no control over how that department maintains their services. I mean, they've got some control, some influence, they can talk to them. But can they actually impose a requirement to pitch up and fix a ceiling, make sure that there's preventive maintenance in place, that the generators are working, that the lifts are working, that it's not a fire risk, such as we've had at Charlotte. And it's worth reading exactly what they found at Charlotte in terms of a fire inspection. The stuff that is improperly stored. These places are meant to be audited by the so-called Office of Health Standards Compliance, who's meant to be accrediting organizations who will be allowed to contract to the so-called NHI. But on the private sector side, as the health market inquiry has pointed out, some of what the apparent slickness of the system and how it operates is deceptive. It's a very costly system, and there's structural increases in costs that are diminishing the quality of benefits that are available to people over time. It's a complex problem to address. And if one feels that both these systems have assets that you don't want to burn down, and these ones that you don't want to just turf, then you've got to understand the systems that are resulting in their particular failures. Understanding exactly how these systems operate is where you start. It's not coming up with some kind of abstraction of a health system and then saying we want that one. Because if I say I want to create a rocket to the moon, I can create a plausibly looking rocket in an afternoon. It's not going to fly, but I can clearly draw one and potentially make you even think that I know something about it. The reality is that you put me in a position where I've actually got to make that rocket, it's not going to fly. Now that's what we're doing pretty much with our health systems design. You don't start from that point. You have to have people that are invested and understand these systems at a very deep level. And they're the people that are prioritizing what you need to fix next, because there are many problems in both systems. So the health market inquiry tried to look at this as a system. It could have looked at it as, oh, there's some people who are basically colluding and we need to put them in jail. Oh, they're colluding all over the place. There are people paying kickbacks all the way through the private health system that are distorting how the system operates and functions. So the question is, how do we address that as a system? Because you can arrest a few people and stop them, but it's not necessarily going to change the system. All you're going to do is change the players in the system. Very much the same in the public sector. We have the perception that we're following up corruption, but corruption is only a proxy indicator for failures of performance. It's just an extreme indicator. It's coming to the surface that you have this extent of blatant, barefaced corruption that ministers can stand there and say, I knew nothing about all of my friends getting these contracts. I know absolutely nothing. I just don't know how it happened. They're speaking to me every day. They used to work for me yesterday. They're now in this company. They're sending massive invoices into this organization that I'm meant to be in charge of. And I'm the one who wants to be in charge of NHI, but I have no idea where these guys are getting their money from. You know, who's hiding what from you then? The issue is that is part, again, of a systematic problem. That we've allowed the way in which our public service is designed to actually allow the executive to interfere in the administrative decisions of the state. That includes public entities, it includes the administrations themselves. So by not having created a coherent barrier between the administration and the executive, we've effectively created the state capture opportunities. And I want to distinguish between petty corruption, which is what Nicholas Crisp would target when he talks about what NHI will eliminate, and he's going to put in all sorts of systems, promises, that will eliminate corruption in NHI. But nothing will deal with the structural separation of the executive from the administration. And it's your ability to appoint everybody on every side of every contract that gives you the ability to capture. So state capture is capture. It's not petty corruption. It means that you are in a position to control the entities that have been set up and use the authority of the state for private gain. So somebody who's basically stealing stuff from a hospital is not using the authority of the state to steal. The person who's using the authority of the state to steal is the person who's basically allocating tenders, who's licensing organizations and won't license you unless you pay kickbacks to the governing party or to yourself. Those are the risks that are set up with a badly designed system, and until we address that systemic gap, our public systems will not operate effectively because they are not focused on resolving the problems of attempting to provide healthcare and public value. So these two require a solution. The reality is that you cannot create a final solution in abstract and chop both of these systems and put them into a third system that you've never had before, which is basically what the NHI bill purports to do. Without any understanding, it's very clear from the bill itself, no understanding of the current systems. The people who drafted that bill cannot understand the South African health system at anything but the most superficial level, you know, the equivalent of media reports. So if we had to look at a 5 to 10 year scenario with where we are, can we just stay still? And I'm just going to, sort of just run through a risk. If we do nothing, what's going to happen? Because these are systems, they're kind of tankers moving in a particular direction slowly. The medical scheme system, if we have no systemic reforms as proposed by the Health Market Inquiry, it's possible that we will see, due to the cost increases, we see Discovery putting out a sort of 5.9% increase on its contributions this year. 5.9 despite the fact nobody went to hospital last year. Massive surpluses. Their costs went down, they didn't go up. 5.9% is going to be the baseline for the cost increase going into 2022. So then they say, no, it's the average of that. You just have to look at the average increase is just half year of this 5.9% increase. No, it isn't. It's going to create a baseline for the 2022 increase. So it's a massive increase. And it's not justified by the costs that the medical scheme actually incurred. Plus the projected costs going forward. It's based on nothing. It's just, as many people in the insurance industry know, keep the people paying high premiums, get them used to it. Don't stop them getting used to these, because then the next time it becomes more difficult to introduce these increases. Now we do have in the system, the Market Inquiry is saying we have a hugely concentrated system in which there are vertical and there are horizontal relationships that are causing similar problems, but not the same, in exactly the same, but similar kinds of problems that you'd find in the state. Very few gatekeepers. And a private sector, when it has very few gatekeepers, does not have a free market, it does not have a well-functioning market, it basically has people who can determine what happens to you, and if you don't like what they want to do to you, basically you can stuff it, because there's nowhere else to go. That's the whole point of a monopoly. So the risk going forward is that we will see systematic de-insurance. You will not see a collapse. And the systematic de-insurance is basically your high-risk groups, your pensioners, etc., lose any access to a cross-subsidy within the medical scheme system. Their pension systems no longer support them in the post-retirement period, and they are the high-risk group that insurers should cover. But they're also the high-risk group that hospitals in the private sector depend on for their income. They're not there for the young and healthy. We've capitalized the private health system on the basis that we've got lots of old people, lots of people who are sick with chronic diseases, lots of people who require oncology, etc. Well, if you eliminate the post-retirement group, don't expect them to come to a private hospital. So the risk there is that there's a de-insurance which has a knock-on effect on the provider system, with the possibility that in fact there's been an overcapitalization in the private system. That will be revealed. And the market inquiry indicated that. There's a concern there that in fact the supplier-induced model that has driven the growth of the private health system to date, which is problematic and driven up costs, has also resulted in a potential overcapitalization that basically was very useful under COVID, but could prove to be problematic down the line when the patient demand starts to dry up because the medical scheme membership structure has changed materially. So what you have then is an out-of-pocket market for primary care which will expand because people who drop out of this system still buy their services that they can out of pocket. The people dependent on the public sector, you're going to continue to see institutionalized corruption relying on the failure of efficient quality of care, particularly for major medical services, and you'll still have deficient primary care. Consequence, out-of-pocket market for primary care will expand, but that's not an insurance market. So the non-insurance market continues to expand, and more catastrophic care ends up in the out-of-pocket market, and that's the risk. That's when your systems of financial risk protection are starting to fail overall. You also don't have cradle-to-grave coverage. So fiscal pressure will make sure that the growth, budget growth is below the growth in the catchment population as well, so you'll have a declining per capita value in the state services. So this, when you look at it, when we do nothing, there is a problem. And this is the problem that if we had people in government who were doing their job, they would be focused on. But I can tell you now, the health market inquiry is going nowhere in the state. They don't actually have anybody to understand it, firstly. They don't really understand how to use the institutions of government to actually implement any of those reforms. The capability within the National Department of Health has been stripped to nothing. It is really very, very weak. And that's one of the reasons the test for that, the proxy indicator, is the National Health Insurance Bill, because nothing but an idiot could have drafted it. It's so out of touch with any part of our health system that it cannot have been drafted by professionals. That's the only way to look at it. And I have been working in government policy since 1989 to now. Nothing but. This is such a downgrading of the quality of government policy that it is seriously troubling. So how should we conceptualize a strategic approach going forward? So you've got one particular approach is that this might be our existing trajectory. So you could say, yeah, what we're going to do is create an ideal end. I draw my rocket, basically. And this is, we create it in concept. And basically all we have to do is create a pathway from where we are now to that point. So it's a great leap forward. So those of you who can have some sense of China and Soviet history will know what great leap forwards achieve. And they're very much conceived on the same basis. The logic tends to be, with those kinds of conceptions, is that you're looking at an idealized endpoint that typically involves a zero-sum game. Somebody has to lose in order to achieve your endpoint. plus no prisoners on the way. The actual consequence of a great leap forward, okay, is that you do actually elicit, you even develop a worse pathway than you were on before. And this is the danger of great leaps forward, of overambitious, abstracted policy reforms. So what should one really do? So we're on that pathway. You have a strategic goal. Strategic goal is not an abstraction. It's a compass point direction. It's a penciled in direction. Certain objectives, certain things that need to be achieved over time. Then you realize that you might have to actually almost reverse to get onto a new pathway. You want to get onto a pathway toward that strategic goal, but you're going to have to start somewhere. Here's where you are, you're on this trajectory, but you know that by the time you've started to work on the proposals, you're only going to get to the point of achieving some structural change maybe a year and a half down the line. So you might actually have some static movement within the system, but you want to get on this trajectory and off this trajectory, and that's your first objective. So we need to sort of precisely understand where we are, therefore. What is our current trajectory? By when can we intervene? What is our first best improvement? And what is needed to secure an improved trajectory? That's how you conceptualize a strategic way forward. If you look at what we've got in the NHI bill, it doesn't look like this. Because try and find an understanding of where we are. Anywhere. Out of 11 years, there's no situation analysis. You will have a paragraph on, we have a two-tier system, and we must have a one-tier system. That's it. There's nothing else. So the issue is that a situation analysis in a complex system like this is potentially done in parts of the system. Where is our emergency medical services at this point? You know, it's quite interesting. We don't have a single proper emergency medical services number. We don't have a 3-digit number. We expect people to memorize a 5-digit number at minimum. In some provinces, you have a 7-digit number. And I was at an interesting meeting with one of these provinces at one point, looking at their emergency medical services, and I'd noticed driving up there were signs with the number on. And by the time I got to the meeting, I couldn't remember the number because it was too long. So I asked the person in charge of medical emergency services in that province, what is your number? He said he doesn't know. So you think, here's an intervention, an institutional intervention, an emergency number. From 1994 to now, we don't have one. You have if you now go to an accident scene, what's the likely scenario you're going to face? Is it going to be a public sector ambulance or a private sector ambulance that arrives first? Almost guaranteed the public sector ambulance will not arrive until very late in the day. Something's wrong with a system that does that. So the issue is, it's not that it's private, it's that the public system has failed so badly. There was one very interesting incident I noticed a while ago, and I think we see repeats of it all over the place, where private security had arrested somebody after a particular incident, a car hijacking or whatever, somebody had commented in the newspaper that the police hadn't arrived for 2 hours. And so when the police were interviewed to ask why they hadn't arrived for 2 hours on this particular scene, it was subsequently discovered that nobody called them. So again, those are the things that are telling you something about how the system is operating. You don't bother to call the police anymore because they're not going to come. If they come, they're going to be too scared to do anything. You call private security, and that's a problem, because private security can't solve many of our security requirements, personal security, investigative results. We now have more money being spent on the VIP protection services than on the Hawks. What is that telling you? They cut the budget of the Hawks, they increased the budget of VIP security, of the VIP services. What country does that? So the point is that in our public health system, there are many problems that mean that you've got to look at emergency medical care, hospital care. You've got to look at the governance arrangements for the academic hospital system, which is potentially different to that for regional and provincial tertiary care, because you've got co-stakeholders involved in those arrangements. Who owns them? How is money to be arranged? Are you going to look for those academic services to have multiple points of service, multiple sources of revenue for those facilities? They're immensely complex. We have no process to examine the future direction of academic hospital services in South Africa. That's a big one. Nothing for emergency medical services. Nothing for forensic services, which are sitting there with piles of stuff that's unprocessed. So how are you prosecuting all of these criminal cases when you don't actually have the forensic services operating efficiently under the control of the Department of Health in the provinces? No proper institutional structure or design. Mental hospital services. A specific design is required around mental hospital services and a governance framework around them. The clinical governance frameworks that I mentioned are quite critical to the well-functioning facilities, whether private or public. You need to have a regulatory framework around that. You need to ensure that there's independence in the investigations, that nobody from a political party can interfere in the investigations. People are terribly scared within the provincial health services of actually having an independent regulatory structure that can actually investigate medico-legal the medical negligence and adverse events. And the Office of Health Standards Compliance is all appointed by the executive of the National Department of Health, National Government. Minister of Health appoints everything in the kitchen sink again. So it becomes a political decision as to whether or not they investigate or do not investigate, or whether they get more personnel, or whether they get more powers. That's not how a regulatory structure operates. So there's all of that. So your quality assurance framework, your approval of private hospital systems and how you regulate them. Each province decides by itself, and MEC decides on who gets a license. All sorts of odd decisions happen at that level. They collect no information on the private hospital system. They couldn't even supply anything to the health market inquiry on the licenses. They have no idea. They can issue licenses for numbers of beds, but they don't actually even know how many actually get activated. We basically don't have a government in charge of our public health system. So the issue is that these are the areas where we require consistent, considered reform that is prioritized. So, so the weaknesses in the current NHI proposals, just very quickly, they're over-optimistic about the achievability of the endpoint. There's a misdiagnosis of systemic weaknesses in the health system. Misdiagnosis is actually being a little kind to them. There is no diagnosis. Capability weaknesses in the state to take forward even achievable strategies are largely due to institutionalized patronage that has largely destroyed the integrity of state structures. So the issue is the capability of the state is severely damaged. It can't do things. The retention of unaccountable patronage-based governance approaches for all proposed organizations and regulatory frameworks continues. Every regulator is a ministerial appointment. That's why you have the Health Professions Council running off its mouth in Parliament about the NHI bill. Is that an independent regulator? Anybody that's going to have any independence would be shut up in our current structure, because politically you're not allowed to say anything that isn't approved. So the fact that they've said that means somebody's condoned it. It's not because it's actually a real voice that's coming out there of somebody who's really thought about the future of the health system. It's some political deployee sitting in that organization saying this stuff because it's convenient for it to create a noise of a sufficient kind, to signal where they stand. And the stuff is just crazy nonsense that comes out of that. So, by the way, if you take it seriously, I mean, don't lose sleepless nights over it. They're so far off. They have no idea what they're saying, don't understand the issue. They're merely signaling. And nothing of what they say will actually be implemented. So institutional proposals involve destroying existing coverage approaches before new ones can be tested and implemented. There's nothing been implemented. We've had 11 years of so-called pilots. Pilots have tested nothing. So there's no actual kind of a realistic assessment of systems and processes and testing any part of the proposals. Nothing. The pilots revealed nothing, did nothing, were not systematically implemented. And if anything goes to court in future, and one is basically asking, what did you base A, B, C, or D on? They can't refer to their 11 years of billions of rands spent on pilots that did nothing, in which they didn't even have a proper system of evaluation. It's fiscally impossible. So one thing, just to be clear, I mean, the intention is to increase taxes equivalent to what we're spending in medical schemes. And I have to hear, I mean, people like Nicholas Crisp, they're not people who understand public finance. There is no way that you can increase taxes equivalent to what people are spending in medical schemes. We're at the ceilings of the tax bases. If there is additional money that is raised by the state, I can tell you now it's not going into NHI. It's going into other priorities. So the issue is, you can't say, we are going to get this money. So the question is, what are you creating the institutional framework for? Because you're never going to be able to substitute the medical scheme system practically. Because the money that people pay into medical schemes is in fact not raised by taxes, it's voluntarily contributed, which means there's a willingness to pay it. That's not the case with taxes and how tax bases operate. So there are constitutional challenges likely on the financing role of the provinces, which has been pointed out. And I just want to make this point clear, because Patrick has made a point about it as well. But I just want to make another aspect clear, and I'll sort of reinforce it a bit if I'm not running out of time, is the issue is that the role of the provinces in the Constitution is that they have autonomy. And we have this system of an unallocated conditional grant that goes to the provinces, and it's important to understand the logic of that. You see, South Africa had two options. I mean, I was part of the discussions on designing the overall fiscal federal framework that we have. I do know why these things were done in the past. The issue is that you could either allow provinces to raise their own taxes and then implement a tax capacity equalization mechanism, so that you share the fact that Gauteng can raise more taxes than Limpopo. So you actually have Gauteng raise the money, and then you create the equivalent of an equalization fund out of the tax revenue to ensure that all the provinces share the revenue that are raised by the provinces. Now, it's important to note that that logic is consistent with the idea of provincial autonomy, that you raise your own taxes in order to prioritize your own public purposes and your own public goods and services. That's the logic. But it was thought it's more efficient to just have government raise the money from national taxes. It's easier and quicker, and then allocate it down through an unallocated provincial equitable share framework. But it's important to note that that allocation is in lieu of provincial taxes. It's unallocated because of provincial autonomy. It's not available for government to just nationalize. It's part of the constitutional framework, which says here are all the functions over which provinces can make their own determinations. They have powers to legislate, powers to raise taxes. They have powers to do things. In healthcare, it's a very general statement. It's health services. They can do a lot with that. And only under certain narrow instances is government able to override that autonomy. It's not large, it's narrow. Government would have to actually show that what they're supposedly equalizing, or what they're shifting to national, actually complies with the requirements for setting national norms and standards, which, I might add, since 1994 they have failed to do. You know, there are no national norms and standards for provinces for a basic package of services. There are no nationally instituted staff to service ratios. There are no nationally instituted staff to population ratios. You can set up those norms and standards even without allocating the budget for them, but you must be careful about creating unfunded mandates, which is a requirement of the PFMA. So when you do that, you must be sure that when you create norms and standards, they must be consistent with the available budget. that people have. And you cannot create norms and standards which exceed the available resources, because then they have a legitimate reason either not to comply with the norms and standards or not to spend the money. So the issue is that that structure exists, and it's a national competency to set those norms and standards, and yet they've set nothing. They haven't set anything around basic services, protocols for treatment. They've got some formularies that they apply, but you don't require an NHI to have a formulary. They have certain things that are procured on tenders at the national level, at least the prices are set. But that doesn't imply that you take over the autonomy of the provinces to do the rest. But the issue is national government has done about 10% of what its powers allow for in setting those. But now it can't think, it can't conceptualize how to use its powers properly, so it just wants to take everything and put it into that, when they haven't been able to do the minimum up until now, which tells you again, it's a proxy indicator of the capability of the people making these proposals. They really don't understand what they're doing. So, the risks associated with the reforms are that the government basically lacks the capability to take forward any reform framework, even correct approaches, and I think this is a serious worry. The existing proposals are a proxy indicator of general capability weakness. So the question is, what are the hard realities? The fiscal position of government doesn't allow for a consolidation of the health system under one general tax-funded scheme in any of our lifetimes. You can pretty much forget it. It really doesn't matter what a Minister of Health says. It doesn't matter what they put in a bill. It really doesn't matter what Nicholas Crisp says. You can't do it. It just can't be done. So it's a hard reality. The public sector is too infused with patronage to coherently reform for the foreseeable future. The private sector is likely to shrink, increasing the levels of overcapacity on the private provider system. That is a risk. Private assets, however, are more likely to exit the system than to be absorbed by the public system. We would just lose them. That's a danger. It would be better that we have a system that basically uses our assets efficiently and doesn't allow them to disappear. The public system will decrease in availability as demand increases without additional resources. That is going to continuously happen. So how should we think about the problem? And it's important to sort of look at a difference, a conceptual distinction that I'd make between best practices and best fits. It's an important idea to get if you ever work in government, or somebody who's has to look even at a private sector organisation and decide on a future strategy. Best practice means you shop around and you find, oh, well, they're doing this in Germany, so we should do it. Or they're doing this in Mexico and we should do it. That's a best practice approach. The problem is that the best practices might be very context specific. That means that the capability requirements are not present locally. So even if you had to look at a country that's at a peer level, what they're doing in Chile can't necessarily be done in South Africa because the political structures are different. The way in which many of the stakeholders are organized are quite different and very specific, so sufficiently specific to make many detailed aspects of a set of proposals unviable in your context. So you cannot say, oh, well, you know, they have a particular kind of process to run their primary healthcare system. Well, you can't just cut and paste it. So this is actually what happens, is that if you create attempt at best practice, very often this is your capabilities, and capabilities refer to your sort of institutional logic, your explicit, implicit rules, your behavioral norms, your trust levels. All of those things are very important to explain your capabilities at a point in time. And here's your task you give yourself because you went and chose or cut and pasted something from the UK. Okay? You're just going to fail because your capabilities are not equal to the task that you've set. This, to me, screams at you from the bill. This is basically how you take a best match approach, is that you understand your capabilities and you set a task that are equal to it, even if part of your process involves enhancing your capabilities over time. So basically your strategy can involve boosting your capabilities and increasing your tasks over time. If you don't do it that way, every single strategy will fail. And the why they say in South Africa is we have beautiful policies, but they never get implemented. It's because all the policies are like this. It's not that they're beautiful, they're all stupid. They're not real, they're paper plans. And the way in which you actually implement something that's genuine is that you have to have a complete immersive understanding of your capabilities and understand the priorities that you've set yourself in your task. And so in this task, what you want to do is to make sure that your highest priority targets for policy at a point in time are the most important things you have to do next, because there's an infinite number of things that you may want to do. But there's only a limited number that you're going to attempt at any point. And you have to be clearly focused on what those are. If we had to understand the problem in South Africa, is that in the public sector we have a multi-level system of government and a system of conditional grants required to institutionalize national priorities. So it's important to note that national government also has substantial amounts that it allocates as revenue to the provinces on a conditional basis. So we will give this to you on condition you spend it on your HIV and AIDS program and TB program. We will give this to you provided you're spending it on health, on tertiary services, etc. So these conditional grants in South African government, the largest conditional grants are in health. The governance of the provincial administrations, we have to eliminate political appointments, basically separating the executive from the administrations, and this includes the regulators as well. The institutional architecture, we have to look at the functions to be centralized, functions to be decentralized. The NHI framework says centralize everything, and they will talk about, oh well, no, I promise we are looking at decentralization. We understand that stuff. But what they're talking about isn't decentralization. Decentralization is when you're allocating autonomy to another level, not deconcentration, where you're just a subunit of a large corporate structure. Those can be efficiency destroying. As everybody in a large corporate structure knows, they have to spend a lot of time trying to find a way to vitalize parts of a large corporate arrangement. And very often that means giving units and substructures a degree of autonomy to set their own strategies and to move forward. That's not what's proposed. What's proposed in this framework is to centralize all key parts of the system. So if we look at the private sector at the pooling level, we do need income transfers. The issue about the tax credits, it's actually not something to just give away. It's part of people's constitutional right. Our Section 27 rights are being provided for in the medical scheme system, and government is making an allocation toward that which on a per capita basis is less than what is being spent on people in the public system. It is a legitimate allocation within the context of a universal coverage model. And that's because everybody above a certain income does not have access to free health services in the state. It's important to note the state is means tested, and it has been ever since 1948. So the hospital system is not free for people who are on medical schemes, not free for people in households. It's a means test, not an income test. So not that they can actually analyze a means test at point of service. It just creates corruption in the administration. But the logic basically says if you earn too much, you have to pay for public services. And that means that you can be financially ruined accessing services in the state in South Africa if you do not have a medical scheme. So the medical scheme subsidy is actually in substitution for the in-kind subsidy you would have received if you accessed the state services for free. That's part of a coherent design. All countries that have universal coverage models have a version of this. We just have a very imperfect version which is subject to discretion. So we actually have to design it properly, which is what the Taylor Committee of Inquiry and the rest did. Risk transfers are horizontal transfers. That's basically from people who don't need health services today to people who do. It's worthwhile noting that that's the kind of coverage that people are paying for, topping up their coverage in the private health system today. They're basically paying for horizontal transfers, not vertical, not these ones, the income transfers. They are paying, people who are on medical schemes are paying the vertical transfers because they're paying an income tax, they're paying through taxes into the state system which finances that. So we do have a system that actually of cross-subsidization. So a very limited amount comes back to people in this pool, but a substantial portion of what they're paying in taxes goes into the state. So if you want to improve this transfer between the two systems, then you look at your government budget allocation and change it if you're dissatisfied with it. What you don't do is just take this away, because what you're doing is you're disrupting a system that you haven't understood where you haven't understood the consequences. Because if suddenly all of the lower income people, including pensioners who are just grasping onto coverage, drop off, well, where do they go? They go into the state system. The state hasn't got services for them. So on risk, you've got a prospective and a retrospective framework. So horizontal transfers within this are very important, and this is where proposals for risk equalisation, social reinsurance that you find in the Taylor Committee of Inquiry, the original NHI proposals of 1995, all proposed that you have a risk equalisation mechanism in the system which would finance your minimum benefits. You have to have transparency of choice for users at the funder level, provider level. And you have to have also governance of the institutions, the regulators. And we have a problem here in that the Medical Schemes Council is a set of political appointments. Now, it is not an independent regulator. That's not how regulators should be. It means they're imposing political decisions, and there's the possibility that there's discretion that's introduced into regulatory decisions that shouldn't be there. And the Council for Medical Schemes it has no role in the strategic integrity of the health system, which is what it should have, as would the Health Professions Council if it were properly designed, and as would all the other councils that are set up. And there's the governance of the private actors, which is the accountability of users to the general public. These are areas that do need to be sorted out. Transparency. I have no idea of my choices in the system, and yet we have a private system where the institutional integrity depends on me having a choice. My being able to say I'm dissatisfied with this particular organisation, I need to be able to move to another. If I do not have that information, and if I'm constrained in any way from that movement, the system gets worse, as it does in any political structure and as it does in any state structure that allocates powers to itself, that establishes a state monopoly. I realise I'm running on a bit long. Maybe you can indicate, is it okay if I continue for a bit? Because I'll go through some specifics on a reform framework, which I think might be sort of useful. It's just in the shade there. This basically looks like, this is a sort of a quick and dirty version of our health system. We have a general tax funded system which is funds are appropriated to health. At this level, we pool funds in the public national health system. So when people say we don't pool, we do pool. It's pooled the moment you pay taxes on the basis of your earnings, which we do. You give that to government and they allocate it. That's a part of the pooling. It's a question now as to how government distributes that. If they don't allocate it coherently, the pooling is dysfunctional. It's because government is dysfunctional. We have a system of conditional grants and a provincial equitable share formula, apart from the few National Department of Health functions, which are a small fry compared to overall expenditure. 33% of provincial revenue comes from these transfers going to health. These are then appropriated. So the idea in national health insurance is that there will be no revenue coming to provinces anymore in respect of for appropriation by provincial government. So it's undermining their autonomy over this function. The idea is that they would buy the services from a province. That means the money doesn't come in as revenue, it comes in as a claim. It doesn't come through an appropriation system, it's all appropriated at a national level. So basically this entire system would go. So at the moment, provincial tier organises the financing of healthcare and the provision of healthcare. Private system, we have contributions and we have the tax credit. And we have medical schemes purchasing the care, and we have some benefit and access guarantees through the Medical Schemes Act. And then you have the provision of care, which is subject to the system. So this system is its coherence depends very much on how this works, how well that system works as well. So the NHI, this is the changes it proposes. So basically eliminate the tax credit. So basically it takes the medical scheme system out of the universal coverage model. It says medical schemes are no longer part of providing universal coverage in South Africa. Only this system will be. These are taken away because all pooling is going to be there. This organisation and financing of healthcare is removed at the provincial level. And so you have the provision of healthcare. Provinces basically become providers. They're not organisers. But the Constitution says you have powers, devolved powers, over health services. It's not at the discretion of the state to basically through a mere bill to take away those constitutional powers. So this is what the final framework would look like. Basically, it contracts with facilities, they provide care. And they might contract with the private sector as well. But your universal coverage model, basically parts of that theoretically fall into the system depending on how much money they can appropriate into the single framework. So there's quite a big change, because at the national level of government they don't do any of this now. They don't do anything in the private sector. They know nothing about contracting. They have no capacity for this. So it's a completely untested model. So again, refer back to this issue. What they're setting is, even if it were a desirable objective, it's a massive task. And so it's unlikely to succeed. So let's look at the alternative frameworks that have been discussed in South Africa that are actually in policy papers that government has produced itself. So we start off with the same system. So essentially the blue parts are what have been contained in reports to date on restructuring the health system. It doesn't propose to change the overall architecture. But what it does say is that it's actually going to incorporate the medical scheme system into the universal coverage model much more substantially than at this point. By doing that, it would look at the redistributive pooling of funds, that vertical transfer system. The tax credit would need to be restructured into a per capita allocation, not a tax credit. So it's actually something that you can define as an appropriation every year, not something that MoMo deals with in National Treasury, but something that is actually dealt with by Parliament as an appropriation. This should become an appropriation. On this side, as the Health Market Inquiry has recommended, you have a risk equalisation social reinsurance structure that basically makes sure that the pooling around a basic benefit in the medical scheme system is everybody faces the same position. For those that aren't familiar with those kinds of proposals, essentially what they do is that they mean the end point, the outcome would be that if you go to a Discovery Health or you go to a Bonitas, they will be offering a basic benefit package which is identical in terms of its coverage, but they might be at two different prices, depending on how efficiently the different medical scheme is negotiating. But their prices won't be different because of the demographics and risk status of their medical scheme, because these equalization mechanisms will have removed that difference prospectively and retrospectively, without going into the technical detail. But what it means as a practical thing for consumers and people working in the system is I can choose the basic benefit package at Bonitas or the basic benefit package at Discovery based on price and some indicator of the quality of the coverage they're offering. In other words, who have they contracted with? Are they actually decent suppliers? Your advisors in the system would be saying, no, don't go with them, their network crap. These are the quality assurance indicators that show you're actually buying into, it might be cheaper, but it's a suboptimal structure. But now you've got an alternative in which you're deciding between alternatives. So this is very often how you accentuate markets and make them work more efficiently, is that you standardize the coverage, the benefit itself, but you allow the providers themselves to change what's inside that package. It's up to them to try and attract people to their packages. So this is the concept that is incorporated in the Health Market Inquiry framework, aside from a number of other features which go to enhance this framework. The pooling part you keep at a national level, but you don't have purchasing at this level. Government doesn't buy the services at this level. It basically transfers the funds to organizations and entities at a devolved level who basically make those arrangements. So technically what's happening in the state is an equivalent to this. This pooling here gets allocated to provinces on an equitable basis, and they have devolved powers to decide how to actually allocate those to get the best value for money. So the architecture doesn't change, But aside from that, all the governance issues that I've mentioned before have to come into this, have to come into the regulatory frameworks. This is a detailed reflection of everything that has been in proposals to date, including ones that have been in Treasury. The framework is quite at odds. It builds on the Taylor Committee of Inquiry, the NHI proposals of 1995, the Interdepartmental Task Team on Social Security coordinated by National Treasury within government, as well as the Health Market Inquiry itself. So within that framework you have what I've described as the possibility of 3 different fund pools. A social health insurance dedicated public fund, but it operates as a competitor, as a market maker, as an alternative, as a default scheme within a medical scheme system. It just means that you've got this as an alternative if you don't want to choose that one, or if you don't want to choose that. You will have a universal available to all unconditional subsidy, which crosses all these systems. But if you're in a medical scheme system, this is allocated to you as a financial amount to bring down the value of your contribution. If you're in the state system, it is the funding the care that you provided. It's an in-kind benefit. The medical scheme system would be subject, and the social health insurance environment would be subject to risk equalization and social reinsurance. Social reinsurance is a retrospective allocation based on actual claims. Risk equalization is a prospective equalization mechanism based on the risk groups that are in. This means that these people are all offering basic benefit packages that are equivalent but might differ in price because of the provider systems that they're accessing, but it's their choice. Your provincial health administrations receive tax revenue. There's this component which was discussed in the Interdepartmental Task Team on Social Security, which deals with the mess that we have between the Compensation Fund and the Road Accident Fund on providing services for people who are facing trauma-related emergency services. And the proposal there was really to create a universal national scheme around that, in which you'd potentially reinsure medical schemes for their emergency services, and you would directly fund the state if you're paying for them, if they're accessing them through the state service. But basically, the financial value of this is relatively small compared to the overall cost of the health system. But what it would mean is that every one of us would be accessing the equivalent coverage for trauma-related emergency services, with the possibility of expansion to others. But this would be your only true national health insurance fund, because this is one where you'd pool the funds, but it doesn't mean that you purchase them all at this fund, because you essentially, if you reinsure to medical schemes, it essentially means the medical scheme purchases them, but basically you've compensated them for the cost of whatever or a portion of the cost of what they're buying them for. So this would have been an important component to clean up our trauma-related emergency services in South Africa, but it would require a big systems reform. And public and private providers should be accessed by any part of the system. In other words, you're looking at the public system that can contract with private, private with public, partnerships, anything can happen. So basically what you want to do is, over time, is to have this system evolve toward, co-evolve in an environment which is conducive toward basically bringing all our parts of the provider system into a shared system, but on a contractual basis, where value makes sense. Under this framework, if this, with all the governance reforms were introduced, the state itself, if it starts to provide poor services, people are going to, if they've got income, they're going to opt into this framework. If this system gets too expensive and the state is providing value for money, people will shift that way. So this basically was a concept which involved creating competition between systems, as well as competition between funders, as well as competition between providers at every level. This isn't necessarily harsh competition, but this is basically competition which allows for value-adding incentives to be in all parts of the system, and becomes an additional accountability feature on all parts of the system, over and above your more static governance features. In other words, a market is an institution. It's an institution that applies consequences to people who provide bad value. If you have monopolies, it doesn't work, whether they're in the state or in the private sector. So this kind of framework creates ease of access all the way through, movement across the system if you're dissatisfied. It's not that it's immediate and you make these decisions. If you have just 10% of your population making these value-based decisions over time, it will impact on the accountability of the entire system. You don't need 90% to change behavior. But you have to bring the barriers down to people being able to exercise a degree of choice as a further institutional intervention in order to improve accountability overall within the system. So this is what's proposed here, you might see, is it can be regarded as almost equivalent. Is the NHI any more conceptual, any more of an abstract endpoint? The reality is most of this system can be introduced largely through incremental reforms. So the issue is, if you are moving forward with this as your overall framework, certain aspects of this can be introduced without encumbering any other part of the system. You can actually have self-contained improvements in the system. Nothing here stops you from having a separate process to deal with academic hospitals, public hospital governance, and part of the Taylor Committee of Inquiry recommendations involved devolving public hospitals so that they would become public entities that are essentially operating with devolved powers relative to the provinces, and that they can access revenue from both the state as well as from medical schemes. That flexibility introduced into them gives them much more capability to move forward as part of a sort of universal provider system. But the whole issue is a more sophisticated corporate governance design that reinforced their decentralized powers and ability to function going forward, rather than just being the endpoint of some bureaucratic hierarchy which completely destroys all incentives to operate. So this top-down separation, top-down administrative structure that we have is deathly and can't survive into the 21st century and the rest of it in South Africa. And a final point on that, I think at one point the Minister of Health, I can't remember which one, said part of this was, don't worry, we're going to run the NHI like the road accident fund or something. It'll be like that. It's very interesting. I've had very close, examined the compensation fund for many years. Compensation fund was still operating on paper-driven administration systems right up until now. The medical scheme system converted into electronic billing in 2000 and 2001. The compensation fund to date has never actually implemented the technologies that are available in South Africa to date. The hospitals are not operating. They might introduce some billing systems to deal with medical scheme, but it's only for medical scheme members. But they can't even put the ICD-10 codes in them. They only do it for the medical scheme members, whereas actually they should be introducing billing systems across their entire patient group and zeroing the invoice. But what it would mean, the information that you gain, the management, strategic information you gain from a billing system means that you can actually look at your income outgo relative to a patient. Now they only have information on how much a hospital has bought and procured. They have no idea how it left the hospital, mostly in the back of somebody's car. So the issue is you want to be able to have complete information on your system, but we haven't even been able to implement in our public hospitals the systems that are available across the road in a private facility. With technology that now is second nature to much of our private health system, and yet we think our private health system must change. Well, it does have to change, but not that way. So that's sort of provided a lot of detail on sort of reforms. And there's a lot of discussion on many details of those. But to me, the basic premise is that framework that I've mentioned is a compass point. But there are very clear delineated areas that have to be resolved. You do not have to change everything. What you're doing is looking at changes. Even when you look at the medical scheme system and a risk equalization fund, you're changing 3% of the system in order to impact on behavior on 95% of the system. That's a leveraged reform. What you're not doing is saying, I can't actually think of how the system would operate. I have to put it in some other box so that I can understand it. But what I'm going to do is change 90% of the system because I don't like the way it works now. That's not how you do it. Every intervention that I've mentioned there is basically a leveraged intervention. It's a key strategic structural intervention that impacts on behavior and how the system operates. It's not breaking down the architecture, destroying one part of the system. It's not a zero-sum game proposal. It's not saying we think that income earners are bad people and therefore they need to pay more taxes. It's not about saying that the people in the private sector are evil and need to be eliminated and we need to put them into the virtuous public sector, which is running with public sector motives. So I'll finish there.